Good evening, sir. Hello.
Good evening, Praveen.
Good evening, sir. Thank you for joining, sir.
Yeah.
You're traveling, sir.
Yeah. Actually, Praveen, car lo hunna. I'm just reaching. In a second, third case.
Okay. No
I'm in the car
problem, sir.
only.
You can mute mode also. Once you reach safe place, then you travel, sir. Hope you are not driving, right, sir?
Okay.
Eniga, try sharing your PowerPoint, ma'am.
Okay, I'm not driving.
Okay, sir. Okay. Please stay with us, sir.
Okay. Thank you, sir.
Sir, just checking the drive, sir.
Jailal, sir.
Eniga, please try sharing your PowerPoint, Pranav. Praveen, sir. Good evening, sir.
Good evening, sir. Can you hear me?
Yes, sir. Very well, sir. Very well, sir.
Sir, who is presenting first case, sir?
Sir, Nikhil only will be presenting, sir.
Okay, sir. Please give me permission to attend.
This girl had some issue with the PowerPoint, so I'm just sorting out.
I want to tell him all the best. That's why I joined, sir. I have to go to attend two functions.
You had some program, you said.
Yeah,
some function you are attending. You are telling.
Please take care of my PG, sir. He's
Yes,
good student.
No, sir, is there somebody will be no.
What happened to Nikhil?
Sorry, sir.
Nikhil, what happened to Nikhil? Can you call him?
Sir,
Nikhil
Sir,
is
fine. He's fine. I'm just asking to wait. He has checked this PowerPoint. Fine. I think we will. Good evening, friends. We will start this session. Today we have three important cases. Normally we have one or two cases, but this time we are going to have three cases during the exams which are coming up closer. So we have a case of Dr. Shailesh Ade. He's from KM and GS Medical College. And we have Dr. Anthony Iniga. Shailesh is contributed to Professor Aparna Deshpande ma'am from KM Hospital, Mumbai. And we have Dr. Anthony Iniga, kindly contributed by Professor Babita ma'am from Government Tirunelveli Medical College. And we have Nikhilesh from Osmania Medical College.
Nikhil.
He contributed by Professor Alam Praveen. I'm sorry, Nikhil. Faculty panel for the day. Professor Vikas Singh, sir. He is a professor and head of the department at the RML Medical College. And we have Professor Umakant Daud, sir. Again, he introduced by Professor Alam Praveen. He is the professor of the surgical oncology at Osmania. And we have very eminent teacher, the retired director of the Institute of General Surgery at Madras Medical College, Professor R. Kannad. And right now he is the head of the Department of Surgery at Indira Medical College at Chennai. So friends, we will be allotting 40 minutes for each case this time, as we normally finish in 2 hours. So I request the faculty to kindly take note of that, so that we finish, take 20 minutes each for the clinical discussion and 20 minutes for the discussion about the other things. All of them have operative images, all of them have like investigation values, so they'll be able to take it further. So for faculty who have come to us for the first time, normally we allow them to present history part without stopping. And then we allow them to, we go back to the slides number 1, 2, 3, and then ask questions or so. I request you to give the answers if the candidate find difficult, so that they will be able to move it further. Then the same thing happens for the clinical part also. And then we move on to the investigation part. Rajgopal sir, good evening, sir.
Good evening. Good evening, Kalaj. Good evening.
Yes, sir. Yes, sir. So this will be the pattern. And student, if you find difficult, please tell so the examiners, or it is not like a pass-fail mode. It will be like a teaching mode. So they'll be able to teach you and appropriately correct you if there is any error. So we wish you all the best. We wish Nikhil to from Osmania Medical College, Hyderabad. to introduce himself, his unit chief, his head of the department, and start his presentation. Good luck to you, Dr. Nikhil.
Yes, thank you, sir. Good evening, everyone. Good evening, respected faculty and my colleagues. I'm Dr. Nikhil, a postgraduate general surgery from Osmania Medical College. I'm studying under Dr. Pallam Praveen, sir. He's our professor as well as our head of the department, general surgery, Osmania Medical College. Today, I'm going to present a case about swelling in front of the neck.
I could see Professor Kannan sir joining. Good evening, sir. Warm welcome to you, sir.
Hello, good evening. Good evening.
Sir, so we are starting, sir. Dr. Nikhil, please proceed. Sir is in mute mode.
Okay, sir. Thank you. Sir.
Please go ahead, Dr.
So,
Nikhil.
cases of swelling in front of neck. So, a 50-year-old gentleman, resident of Hyderabad, meat vendor by occupation, came to the hospital with chief complaint of swelling in front of lower part of neck for 8 months. Patient was apparently asymptomatic 8 months ago when he noticed a small swelling in front of his neck. Swelling was insidious in onset. It was initially around 2 cross 2 centimeter size and gradually progressed to current size of 7 into 6 centimeters. There was no history of any sudden change in size recently, and it was not associated with any other swellings in the neck. He also had complaints of intolerance to heat since 6 months, as well as increased sweating and thirst. Complaints of occasional episodes of loose stool since past 4 months. He had history of hyperthyroidism since 10 years and was on oral antithyroid medications, which he stopped 15 months ago. There was no history of any associated pain over the swelling. There was no history of any significant weight change recently, but he had complaints of increased appetite since 6 months. There was no history of any dyspnea, stridor, dysphagia, or hoarseness of voice. No history of any constipation or sleep disturbances. No history of any palpitations, chest pain, or any pedal edema or facial puffiness. Also, there was no history of any difficulty in getting up or any joint pains, hemoptysis, or jaundice. No history of any trauma to neck or any radiation exposure to the neck. So, coming to past history, he had history of anxiety and excessive sweating, complaints of anxiety and excessive sweating 10 years ago, which was subsided after starting of medication. He was then diagnosed as case of hyperthyroidism and was on oral antithyroid medications since 10 years, which he stopped 15 months ago. He is not a known case of asthma or epilepsy. No, he didn't have any history of cerebrovascular accident or coronary artery disease. There was no history of any tuberculosis episodes or contact. There is no history of any previous surgeries, blood transfusions, or any allergies. No history of any significant radiation exposure. There was no history of any similar complaints in the family, and patient takes a mixed diet. He has increased appetite with normal bowel and bladder movements and no significant sleep disturbances. Patient is a chronic smoker, 1 pack per day for past 15 years, stopped 6 months ago. He is an occasional alcoholic. Treatment history, he had no history of any antihypertensive or antiglycemic medication usage. But he had history of usage of tablet carbimazole 10 mg BD for the past 10 years, which he was non-compliant and stopped 15 months ago. So, summary of my history, a 50-year-old gentleman, known hyperthyroid for past 10 years on intermittent medication usage, has come with a painless progressive swelling in front of neck with hyperthyroid features and no pressure effects or symptoms of metastasis. So shall I proceed to examination, sir?
Did you say that there
Please
was no
wait,
swelling?
Yes, sir.
Nikhil, did you say that there was no swelling before and only from 8 months the swelling is there?
Yes, sir. Patient noticed the swelling since 8 months, sir.
And for last 10 years, there was no swelling was there?
No, sir. Last 10 years, there was no swelling, sir.
So he was just diagnosed based on the symptoms only?
Yes, sir. Based on the symptoms, he was diagnosed as hyperthyroid, sir. For the past symptoms he had for the past 6 months, sir.
Okay. And this swelling is only for 8 months, because this doesn't look acceptable things, isn't it? That the patient is having the hyperthyroidism for so many years and swelling has come only 8 months back only.
He was using anti-thyroid medication, sir, although he stopped them around 15 to 18 months ago, sir.
Your patient gives history of diarrhea. I think.
Sorry, sir.
Your patient gives history of diarrhea.
Yes, sir. Past 4 months, he had intermittent episodes of loose stools, sir.
Right. So if the patient has a diarrhea in a case of a suspected thyroid problem, what are the differential diagnosis?
Diarrhea can be seen in hyperthyroid patients, sir.
Yes. Anything else? Short history of swelling in the neck.
Yes, sir.
Which other condition, thyroid condition, may lead to the diarrhea? Any malignancy, you know?
Medullary
Yes.
thyroid carcinoma, sir.
Medullary carcinoma of the thyroid, you know?
Yes, sir.
That is one of the presentations in that.
Yes, sir.
This patient was taking carbimazole. How much? What was the dose?
10 mg BD, sir.
Okay. And he was controlled on that.
Yes, sir. He gave history of taking medication intermittently. Like he was non-compliant, sir, and stopped completely 15 months ago, sir.
Dr. Nikhil,
Yes, sir.
one question to you. What
Yes,
made
sir.
you to think that it is a known hyperthyroid?
Right.
First question.
Sir, because he had complaints of features suggesting hyperthyroidism, sir.
Like what?
Sir,
See,
such as,
that's what Dr. Khanna sir mentioned to you. Yes, I have seen this.
yes, sir.
What you are written here, what is the 10 years back what he had? See, that's what is prompting us us to have this basic question. If you see carefully,
Yes, sir.
recent is no problem. You are written heat intolerance, sweating. History of hyperthyroidism, 10 years. What is that he had? 10 years.
Sir, 10 years ago, he went to hospital with increased sweating and anxiety
Where
issues.
have you written that?
In past history, I've written that, sir.
No, that is, see, subsided on taking medication. So you think the anxiety is due to hyperthyroidism? First question. You
No,
understood my
sir.
question?
Yes, sir.
So it only asks you two important questions here. What?
Yes, sir.
Only two complaints for which he went to a local doctor, and whether any thyroid hormones have been tested. 10 years back, he was 40 years old, correct?
Yes, sir.
And anxiety can be due to several factors. And sweating,
Yes,
what is this sweating? Was it climatically, lot of sweating will be there climatically.
yes, sir.
Whether there was any sleep disturbance, whether there was any palpitation, how you get convinced this is basic problem is hyperthyroidism. These are the few questions which will definitely come.
Yes, sir.
So based on these two complaints, you cannot start the patient like this. So you need to, little more details are expected from you.
Yes, patient, he initially told 10 years ago, he went to a local
Correct.
doctor, then he got his
Yes.
blood reports, like he got his thyroid profile done, so the doctor advised thyroid profile, he told, sir. Then he started him on tap carbimazole, sir. So based on that history, I came to a conclusion that he might have been diagnosed with hyperthyroidism 10 years ago, sir.
So what is the most common cause of hyperthyroidism according to you when he was 40 years old?
The most common cause at that age would be any could be Graves' disease or any.
So when the swelling is hardly any visible, it can be Graves. And
Yes, sir.
otherwise, 40 years of age is what is the common problem you get? That
It will be
for
nodular
toxic
goiter, sir.
vessels.
At that age, it will be.
Yes.
At that age, it will be solitary nodules, solitary thyroid nodules, sir,
All
usually.
right, but toxic multinodular goiter.
Yes, sir.
What is the main predominant symptom of this?
Sir,
predominant symptom of multinodular goiter with the toxicity?
predominant symptom will be swelling, as well as clinically patient will be having palpitations, etc.
So that's why
Mainly cardiovascular symptoms will be predominant.
basic doubts, whatever we are having, just based on sweating and anxiety,
Yes,
in
sir.
absence of, other features. It's very difficult to believe this entire story. That's what is the basis.
Yes,
Sir, Kannan sir.
Dr. Nikhil,
Please, sir. Good evening,
Yes,
Dr.
sir.
Nikhil, your
Yes, good evening.
history, as you
Yes, sir.
said, 10 years before, he was diagnosed as a hyperthyroidism. But at that
Yes, sir.
time, what are the features he had and what was the treatment given? It's not very clear. Can carbimazole 10
Yes, sir.
milligram BD
History was
for
weak,
10
sir.
years without any problem? Is it possible only carbimazole?
No, sir.
Or did
Patient
he
will
have
be.
any propranolol or any other drugs? So the treatment history is
So
not
patient
very.
didn't give a proper history, sir. The only history he gave was
Then
he was using
that
Sorry,
is
sir.
one part. The second part you tell is 18 months back he stopped all the drugs and all his symptoms started 8 months
Yes, sir.
back. See,
So 15 months to 2
totally.
years ago, he stopped the medication, sir.
Yeah. You
And
told
since 8
8
months,
months
he
before he
started
stopped.
noticing, sir.
But the
Yes,
problem
sir.
started only after, that is only for 8 months duration. Right?
Yes, sir.
Your features are there for hyperthyroidism. But this
Yes,
past
sir.
history or the treatment history is what confusing everybody. If you consider the
Patient gave a
diagnosis
vague
of a
history,
Graves
sir.
disease,
Yes,
medical
sir.
management, how long you can give a medical management for Graves disease, you think?
So we can try for 1.5 to 2 years, sir.
That's what. No, 6 months they take, or 6 months to 1 year only they consider it a medical management, right?
Yes, sir. Yes, sir.
And if it is Graves disease, with the 10 milligram of carbimazole, I vouch that it will never subside without any other drugs.
Yes, sir.
Patient will have more features like loss of weight, loss of appetite, so many alarming problems like
Yes, sir.
anxiety, everything will come, right?
Yes, sir. Yes, sir.
Right? Being a male patient, that too with the thyroid, you have to be very, very careful when you are getting the history. Okay,
Yes,
what
sir.
are the features of hyperthyroidism you identified in your history?
The patient had a history of intolerance to heat, sir, as
Like
well as
one,
increased sweating and thirst since past 6 months, sir. He also had history of increased appetite, sir.
right?
So
Is there any
it was
significant loss of weight?
no, sir. Recently, he didn't have any significant loss of weight, sir.
No, this past 8 months, what was the weight earlier before and what is the weight now?
So, presently, he is at 65 kilograms, sir. But patient told he didn't lose any significant, like, I asked him any loosening of clothes or anything. The patient and his attender also, they told there is no significant change in weight, sir.
Anticipatory bail.
Okay, Nikhil, go to the examination because you have to finish in 40 minutes. 20 minutes have passed.
Please go for
Go to the
the
examination, yeah.
examination.
General examination. A 50-year-old gentleman, moderately built, moderately nourished, conscious, coherent, and cooperative, is examined under valid conditions after taking informed consent. His hair appears normal. Face is symmetrical with no evidence of any puffiness or flushing. No evidence of any pallor, icterus, or cyanosis is noted. There is no evidence of any tongue tremors or tremors in bilateral upper limbs. Hair and nails appear normal with no evidence of any clubbing or koilonychia. Patient is vitally stable with a temperature of 98.7 degree Fahrenheit, pulse rate of 86 beats per minute, regular normal volume. Blood pressure is 110 by 70 millimeters of mercury in right upper limb, measured in right upper limb. Respiratory rate is of 16 cycles per minute, regular and thoracoabdominal. There was no evidence of any pretibial mixed edema or any evidence of pedal edema. So, on local examination, patient was made to sit comfortably on a stool with neck extended, arms by his side, and inspected from the front. A single uniform, well-defined ovoid swelling measuring 7 cross 6 centimeters is noted in anterior aspect of neck, more to right than left, extending vertically 2 centimeters from 2 centimeter below the thyroid prominence to 1 centimeter above suprasternal notch, and side to side 4 centimeters to the right of midline to 2 centimeters to the left of midline. Right side, it was seen indenting onto the sternocleidomastoid of right side. And swelling is smooth with skin over it showing no abnormal pigmentation, scars, fistulas, dilated veins, or visible pulsations. Swelling moves with deglutition, but not with protrusion of tongue. There was no evidence of any tongue tremors. Tracheal position appears to be in midline, with no evidence of any prominent veins over anterior chest wall, and no evidence of any other swelling seen in the neck. So, on palpation, so sternocleidomastoid muscle is seen pushed on the right side. On palpation, patient is placed in the same position and examined from both front and behind. There was no local rise of temperature or no tenderness over the swelling on palpation. Inspectory findings are confirmed. A firm, smooth, ovoid swelling measuring 7 × 6 centimeters with well-defined borders is noted as described. Skin over the swelling is pinchable. Swelling is mobile in horizontal axis but not in vertical axis. Swelling is deep to deep fascia, and trachea is in midline with no deviation. Bilateral carotid pulses are palpable in normal position with no palpable thrill or stridor over the swelling. There was no cervical lymphadenopathy. On percussion, resonant note was elicited over manubrium sterna and parasternal area. There was no abnormal bruit heard over the swelling on auscultation, and there was no evidence of any lid lag or exophthalmos in bilateral eyes, and conjunctiva and cornea were normal. No evidence of any restricted eye mobilities was seen, and he was classified no specs class. Both bilateral eyes class 0 was given. So on systemic examination, cardiovascular examination was normal with a normal sinus rhythm. Respiratory system bilateral air entry was normal and equal with no audible added breath sounds. CNS examination, there was no focal neurological deficit, and deep tendon reflexes was normal with no evidence of any proximal myopathy. Abdomen was soft with non-tender with no guarding or rigidity. Bowel sounds were present, and there was no evidence of any organomegaly. So, summarize my case. A 50-year-old male, hyperthyroid for past 10 years, has presented with a painless progressive swelling in front of neck with hyperthyroid features and no pressure effects, no eye signs, and no signs and symptoms of any metastasis. On examination, an ovoid 7 × 6 centimeter smooth firm swelling is noted in anterior aspect of neck, which is moving with deglutition and has no retrosternal extension. Bilateral carotid pulses are palpable with no cervical lymphadenopathy. My provisional diagnosis will be benign diffuse hypertrophic hyperthyroid goiter with my probably Graves' disease, or it could be toxic multinodular goiter.
Dr. Nikhil,
Yes, sir.
you were discussing a swelling, ovoid swelling.
Yes, sir.
Right? Then you finally made a diagnosis of a diffuse toxic goiter. See, in thyroid, either you have a diffuse enlargement of both lobes of thyroid, or
Yes,
a focal nodular enlargement, or
Yes, sir.
multiple nodular enlargement.
Yes, sir.
Clinically, you can make only 3 types of diagnosis.
Yes, sir.
But your description is only, you said it is a ovoid swelling. That means you want to, which lobe it is enlarged. Is it bilobular enlargement with isthmus enlargement, or is it related to one part of the thyroid, either that is right lobe or left lobe?
Sir, on
Clinical.
inspection and palpation, it was uniformly enlarged, sir. Like I couldn't make out any right or left lobe, sir. It was uniformly enlarged, sir.
But Dr. Nikhil,
Yes,
your
sir.
description says the lesion is not diffuse actually. You said your description tells that right lobe and the isthmus is enlarged. Then now you have to describe, is there any, what is the status of other side of the lobe? Is there any nodules or is it normal? Your description doesn't stand that it's a diffuse enlargement. You say it's a focal enlargement.
Yes, sir. On palpation, I couldn't palpate any nodules, sir. And swelling was, it was enlarged more to the right side than the left, sir.
That itself says that it is not diffuse goiter, no? Either it can be a part of multinodularity or multinodular goiter, or this itself is a focal swelling and rest of the thyroid is normal. And
Yes.
second thing is the presentation history, it doesn't really suits that the patient had previous hyperthyroidism, and now 15 months back he stopped. Once again, 8 months back he developed a swelling. So it is not really correlating, except for that he has taken a carbimazole. As the other faculty told, it is very difficult to manage without any multiple nodules and all those things. If the hyperthyroid, if he is getting treated for so long years, that patient will develop lot of nodules actually.
Yes.
I don't think patient had hyperthyroidism at that time. So that is one thing. Second thing is now,
Yes,
did you do berry sign? Did you elicit? You talked about bilateral carotid pulsation. That is not berry sign.
Pulses are palpable, sir. In berry sign, pulses will be non-palpable or feeble, sir. They will be.
Where do you palpate carotid artery if you want to elicit berry sign?
Berry sign, carotids can't be palpated, sir. So we look for a
In
superior.
berry sign, you have to elicit this pulsation or look for the pulsation at the posterior aspect of the swelling. Suppose if
Yes,
it is malignancy, it is said that because of the engulfation of the carotid artery, the pulsation will be little low or absent, isn't it?
Yes,
That
sir.
is called berry sign. It
Yes,
is
sir.
not bilateral carotid pulsation, isn't it? Bilateral carotid pulsations are different. If you want to elicit the berry sign, you have to palpate the carotid pulsation just posterior to the given swelling, isn't it? Like that. You have to
Okay.
see, especially in this case, you have to see.
Okay, sir.
He is patient now. Is he eliciting obvious hyperthyroid signs now?
Now, patient is on carbimazole and he was also given Lugol side, sir. Now patient is not having any clinical manifestation of hyperthyroidism, sir.
At present, there is no clinical manifestation of hyperthyroid. So the existence of hyperthyroidism now based on only laboratory findings. You have to.
Yes, sir.
Did laboratory
Findings we have.
suggesting hyperthyroidism?
Yes,
Are they showing hyperthyroidism? Laboratory findings.
lab values, T3 and T4 were in normal limits, sir, and TSH was decreased, sir.
That is the laboratory status.
Yes, sir.
Is any other diagnosis you want to consider in this patient? Now that it is not a diffuse goiter. Do you agree with that?
It could be a, yes, sir. Could be a toxic multinodular goiter, sir.
Okay, that is one possibility. Any other possibility?
It could be also a solitary thyroid nodule more towards the involving the right lobe, sir.
Okay, solitary thyroid nodule. It could have started last 8 months back, isn't it?
Yes, sir.
Right now, lab values are not really showing hyperthyroid. That is one.
Yes, sir.
Can you think of possibilities of any malignancy in this patient?
On long term usage, patient can develop a follicular malignancies, follicular thyroid cancer, sir.
In case of hyperthyroidism?
Sorry, sir.
If any patient is having hyperthyroidism, do you want to establish? Do you want to put malignancy as a first possibility? If patient is having hyperthyroidism per se, say clinical signs are there, laboratory
malignancy
evidence.
patient will be usually be euthyroid, sir. With patient will usually be euthyroid, sir.
Euthyroid, right?
Yes, sir.
Very rarely malignant patients will have hyperthyroidism. Only 1% of the patients, very well differentiated follicular malignancies are functional. Otherwise,
Yes,
most of the times they are not functional. So,
yes, sir.
when there is that is why I asked, is there any laboratory evidence, clinical signs present? That is why I asked. If they are present, you should not entertain malignancy as a first possibility.
Yes, sir.
Okay. Now, what do you want to do for this patient? Then a lot of history is confused.
Because the thyroid profile is showing a decrease. Patient is in hypothyroid status. Next, we have gone for an ultrasound, sir.
At least you say that the patient is having subclinical hyperthyroidism, isn't it? Because
Yes,
T3, T4 is normal, no?
Yes,
so
sir.
he's having subclinical hyperthyroidism at least. Now it is no more hyperthyroid, subclinical hyperthyroidism. Okay.
Yes, sir. So ultrasound was done, sir. In ultrasound, there was an evidence of multiple, like 2 solid cystic well-defined lesions noted in right lobe, sir. The largest measuring 2.7 into 4.8 centimeters with peripheral calcifications. So it was given as a Thyroid 3 lesion, sir. And evidence of similar lesion measuring 1.2 cross 0.9 centimeters were noted in left lobe, sir. With the isthmus measuring 1.5 centimeters. A left lobe lesion was given Thyroid 2 and right lobe lesion was given Thyroid 3 lesion, sir. Following which FNAC was done of the Thyroid 3 lesion and it showed follicular nodular disease, sir.
Okay.
Bethesda grade 2 was given, sir.
It has given what? Follicular?
Nodular disease.
Okay.
So, because it is given as follicular nodular disease and the TSH was low, we proceeded with thyroid scan, sir. thyroid scan, it showed non-uniform multiple nodules of variable intensities noted in right lobe, with suggestion of predominant cold nodule involving right lobe, and surrounding hot nodules were noted in right lobe, sir, with the left lobe showing uniform tracer distribution, sir.
Okay, wait. There is a cold nodule. So what is the significance of that cold nodule?
Sir, cold
There is a
nodule
cold
is a
nodule
non-function.
there is a cold nodule. What do you
Yes,
think
sir.
it is? What is your analysis of this cold nodule? And per se, what is the importance of cold nodule in general? And what is the importance in this patient?
Yes, sir. Cold nodule is a non-functioning nodule, sir, and it has increased the risk of malignancy, sir.
How much increased the risk? Is it 90%?
Around 20% risk of malignancy is there in cold nodules, sir.
So still cold nodules, 80% they may not be malignant. That you
Yes,
should
sir.
remember. Only 15 to 20% they can be malignant. Okay.
Yes, sir.
And what about in this patient? In this
In this
patient, there is a cold nodule. What do you think it is? What is your analysis? Because you taken history, clinical examination, ultrasound, everything is over, no? What do you think it is? This
Yes,
cold nodule, how will you explain? Will you think in terms of malignancy or will you think in terms of anything else? He was on. You said he was hyperthyroid. He was treated. So in these kind of patient, will you get cold nodules? See, this patient was hyperthyroid.
there will be
right?
Yes, sir. So due to prolonged usage of medication, some of the nodules might have developed autonomicity, sir, with the suppression of surrounding tissues, sir. Like some part of thyroid will be uptaking more, and the other part will be uptaking less, sir. So that might be the reason for cold nodule in this patient, sir.
That is one. And what is the other importance of this cold nodule? See, when you have taken a scan, whenever there is a cold nodule, you should ask your sonologist to take biopsy from the FNAC from that cold nodule. So yes, that will tell whether there is any malignant tissue or not, malignant cells are there, or especially papillary carcinoma, you will test.
Okay, yes, sir.
Dr. Nikhil,
yes, sir.
With all the clinical and the associated your collaboratory findings, clinically itself it says it is not a diffuse goiter, right?
Yes, sir.
Your patient you described is only the right lobe and the isthmus. That's
Yes,
why
sir.
you are discussing about a ovoid nodule. One. Second is you never thought about any eye signs. Neither there are eye signs or there is tremor.
No,
right?
sir.
So these are all the things that rules out the Graves or the
Yes,
primary thyrotoxicosis, right?
Yes, sir.
So this has come as per the clinical aspects and the investigations turned out to be a multinodular goiter.
Yes, sir.
Right?
Yes, sir.
But being a male patient with a cold nodule is always dangerous. See, male
Yes, sir.
patient with the thyroid, you have to rule out a malignancy.
Yes, sir.
Right? Can you rule out by FNAC itself? There is no follicular malignancy here in this patient.
No, sir.
Yeah, why?
So because follicular neoplasm malignancy, the main feature of malignancy in follicular regions will be capsular invasion, sir, which we cannot rule out in FNAC, sir.
Right. Capsular or vascular
invasion, sir. Yes,
right?
sir.
So what are the clinical features, ultrasound features to say it is malignant in a case of a cold nodule?
So in malignancy, if a nodule is any hyperechoic nodule or any nodule that is taller than wider, and any nodule that is showing calcifications can be a malignant nodule, sir.
Yeah, these are all the features you have to look in case if there is when you do an ultrasonogram, right?
What
Yes,
about
sir.
calcifications?
Sir, I can't hear you. Sorry, sir.
Can you have they done any the thyroid that is microsomal antibody?
No, sir. Antibody tests were not done in this patient, sir.
Why we have to do?
Sir, antibodies are usually done either in case of Graves' disease or any thyroiditis, sir. Because this patient after ultrasound and thyroid scan, we diagnosed him as toxic multinodular goiter. Antibodies they were not sent, sir, because the diagnosis of toxic multinodular goiter was made, sir.
Yeah.
After
But
investigations.
you have to the toxic multinodular goiter. Still, we have to do the thyroid antibodies, antimicrosomal antibodies to rule out Hashimoto's, right?
Yes, sir. Yes, sir.
Okay. So how will you proceed?
Sir, because the patient is having in FNAC is showing Bethesda grade 2 and sorry, sir. FNAC is showing Bethesda grade 2 and ultrasound is showing thyroid 3 lesion and it's a solid cystic lesion. So I'll proceed with I'll prepare the patient making euthyroid and proceed with the total thyroidectomy and send the tissue for biopsy, sir.
You
And-
told about Lugol's iodine. What is the use and how long you can use?
Sir, Lugol's iodine is a 5% iodine in 10% potassium iodide solution, sir. It acts by inhibiting the release of thyroid hormones from thyroid gland, sir. So it is best like a better option to use to make the patient euthyroid, sir. Lugol's iodine 2 to 3 drops TID is given for 10 to 15 days, sir. By which time the patient he can become euthyroid, sir.
Right. Okay.
Yes.
Total thyroidectomy and then send a specimen for biopsy.
Yes, sir.
Rule would be
If it turns out to be malignant, we'll in the biopsy we will know whether it's malignant or not, sir.
Nikhil, you give the Lugol's iodine to make the patient euthyroid.
Sorry,
That is
sir.
the main purpose of, that is the main purpose of giving the Lugol's iodine.
right.
No, sir. Lugol's iodine, one action is it releases the
What is
inhibits the release
main
of thyroid
purpose?
hormones, sir, so that the colloid accumulates, like the amount of colloid within the thyroid gland grows, sir. This will cause a vascular constriction within like interlobular vessels which get constricted, sir. So the gland will become more firm and less vascular, sir. So the intraop will be
That is the
having
main, okay, that is the
Yes,
main
sir.
thing, that it reduces the vascularity of the while you are operating. You know?
Yes, sir.
What are the other drugs which can be given for control of the hyperthyroidism?
Sir, antithyroid medications like carbimazole can be given, sir, and also propranolol can also be given, sir.
So when you will give the propranolol?
Propranolol, if the patient is having any toxic features and mainly sympathetic features such as tremors or anything, we can propranolol can be given to control them, sir. Propranolol also helps in stopping the peripheral. It also inhibits peripheral conversion, sir. So we'll get a quicker control, sir.
So in every case, you do not require to give the propranolol?
No, sir. Antithyroid medication and Lugol's iodine will be enough, sir. If any toxic indications are there, any sympathetic features are there, then we can give propranolol, sir.
No, in a patient is having
Short-acting
hyperthyroidism. Hyperthyroidism patient is there.
Yes, sir.
So almost in every case, you have to give the propranolol at least for about a week.
Okay, sir.
Okay, it has to be given for a week and it has to be continued afterwards also, after the operation.
Yes, sir.
Otherwise, all there will be sympathetic overactivity will be there. The
Yes,
release
sir.
of the hormone which is there, all will cause problem.
Yes, sir.
Okay.
It
Yes,
helps
sir.
in the reduces the peripheral conversion of.
T4 to T3, sir.
So there is also the another use of the.
Yes, sir.
Right.
Yes, sir.
Any other drug which are given in a patient who is having the hyperthyroidism before you go for the surgery?
Carbimazole,
You have to give the anxiolytic drugs.
Yes, sir.
Okay.
Anxiolytic drugs.
Yeah. And that is why, when you are making a list of surgery for your operation theater, where the patient of hyperthyroidism will come in the list.
Sir, we usually take him for the first case, sir, in the morning.
Yeah. The reasons for that?
Because one thing, if any complications are there, we can manage if the case is taken early. Second, if we make the patient wait, he might get anxious, sir.
So that is why it is kept as a first case. The patient
Yes,
does not
sir.
get anxiety.
Yes, sir.
That can precipitate the problem in that patient. Okay.
Yes, sir.
Yeah. So what is your plan in this patient now? Now, before you go for the surgery, what is your plan here?
Sir, we'll first make the patient clinically euthyroid, sir.
And then?
And then proceed for surgery, sir.
Okay, which surgery?
I'll proceed with the total thyroidectomy in this case, sir.
So before you go for the total thyroidectomy, what are the other investigations you have to carry out?
Sir, we have to do indirect laryngoscopy, sir, to confirm the position status of vocal cords and larynx.
Mhm. Why it is called as indirect laryngoscopy?
Sir, because the larynx and vocal cords are not directly visible. They are visible via a mirror. Like we'll place a mirror in the closer to the posterior thoracic. Sorry, sir. Posterior tracheal wall, and then visualize the vocal cords,
Posterior
sir.
tracheal wall. No? You cannot go to the posterior tracheal wall.
Pharyngeal, sir. Sorry, sir.
Yeah.
Posterior pharyngeal wall, sir.
Yeah. Okay. And what is the direct laryngoscopy? Who does the direct laryngoscopy?
So direct laryngoscopy, anesthetist can do the direct laryngoscopy, sir.
Anesthetists always do the
Sorry.
direct laryngoscopy. No?
Yes, sir.
Yeah, anesthetists do the direct laryngoscopy. Okay. What other investigations are required before go for the total thyroidectomy? What are the other investigations? You need X-ray of the neck?
Yes, sir. X-ray of neck is needed, sir.
Okay. Why you need the X-ray of the neck? And how many views you will do?
Sir, we'll take a anterior posterior view and lateral view, sir. Anterior posterior view to see if there is any tracheal deviation, sir. Lateral view to see if there is any tracheal compression, sir.
Okay. So what is the advantage of seeing that?
We can know if there is after surgery there is a chance of development of tracheomalacia, sir. In case of especially large lesions. So preoperatively we can anticipate that risk, sir.
Advantage to the surgeon and advantage to the anesthetist. AP view.
AP view.
What is the purpose for the anesthetist?
Any tracheal deviation we can get to know, sir.
So the anesthetist will know when he is putting the tube there.
Yes, sir.
That it is not in the midline there. Okay, it is
yes, sir.
shifted to right or the left side. So he will direct his tube in that way. Okay.
Yes, sir.
And for the surgeon also the same thing. No, you think probably the trachea is in the midline, but it is
Yes.
not there.
It is deviated.
Yes. And lateral view for the anesthetist, what is for the anesthetist, the lateral view?
If there is any tracheal compression, he can.
No, he will decide the size of the endotracheal tube.
Okay, sir. Yes, sir.
Based on the compression. No?
Yes,
like
sir.
normally, if you pass 6.5 or 7 tube, he may have to pass only 6 number tube.
Yes, sir.
Because the trachea is compressed.
Yes, sir.
And from the surgeon's point of view is the tracheomalacia.
Yes, sir.
Because the surgeon should know that once he does the total thyroidectomy, the trachea may collapse.
Yes, sir.
Okay. So that is why you have to always do the X-ray of the neck.
Yes, sir.
Okay. Will you do the serum calcium?
Yes, sir. Serum calcium should be done, sir, because there is a risk of removing the parathyroids or devascularizing the parathyroid, sir. So to monitor that pre-op serum calcium should be calcium level should be assessed, sir.
Yeah. So apart from all other investigations for the fitness of the patient, these investigations are to be done in a patient where you are planning for the total thyroidectomy.
Yes, sir.
Okay.
Dr. Nikhil.
Yes, sir.
The patient is a butcher by occupation.
Yes, sir.
And what is the hamburger thyrotoxicosis?
Sir, hamburger thyrotoxicosis is where we ingest pork meat which is contaminated with the animal's thyroid tissue, sir. So there will be exogenous intake of thyroid hormones into our body, sir.
Yeah, because you told that occupation is a butcher.
It's
so
meat vendor, sir. Yes, sir.
This, but remember, a male patient with the thyroid enlargement, yeah, it is possible to get a diffuse thyroid, Graves' disease also.
Yes, sir.
But, the clinical manifestation you're told very clearly, it only points to the multinodular goiter proved by the ultrasonograph, right?
Yes, sir.
And there being a cold nodule, you have to rule out malignancy. The most common malignancy in a multinodular goiter is?
It can develop follicular neoplasm.
Right?
Yes.
You have to rule out follicular. And as you said, you described, and the investigations clearly proved to be, it's a questionable cold nodule.
Yes, sir.
The treatment for that is little bit suspicious to rule out malignancy. Better to go for total
thyroidectomy and biopsy.
No, you cannot treat Graves' disease for 10 years, that too with 10 milligram of BD dosage of
Carbimazole.
what is block and replacement therapy in case of Graves' disease?
Graves' disease will block the release of hormones by giving antithyroid drugs, sir, and will replace them with exogenous thyroid hormones, sir, by supplementing the patient with thyroid hormones, sir.
Yes. So you have to block with higher dosage and then you have to supplement with the thyroxine.
Thyroxine.
Right? That is called block and
Block
replace.
and replace
Otherwise, you have to do titration of the dosage.
Yes,
So you
sir.
cannot give 5 milligram TDS, something like that. You have to titrate to the needs of the patient.
Yes,
right?
sir.
Good presentation.
Thank you, sir.
Nice presentation, Nikhil.
Thank you, sir.
Good.
Thank you, Dr. Nikhil. Do you have any questions, Dr. Nikhil, to doubts or questions to be clarified by the faculty here?
Sir, while studying, I actually got a doubt, sir. Can I ask?
Yes, please ask.
In primary thyrotoxicosis, there will be predominance of CNS symptoms, and in secondary, cardiovascular system is most affected, sir. So I couldn't find out why the preference, like why there is CNS in primary and CVS is affected in secondary, sir. I couldn't find out that.
Actually, primary occurs in the young patients.
Yes, sir.
Secondary occurs in the elderly patient.
Yes, sir.
And in the elderly patients, there is more chance of having the cardiac problems.
Okay, sir.
That is the reason. That is probably the reason that why there is a difference in between this neurological presentation and the cardiac presentation.
Okay, sir.
Okay,
The
so that
primary
is
and secondary, no, we want to discuss, no.
Yes.
See, the manifestations are not only due to the increased thyroid hormone, right?
Yes, sir.
As in multinodular goiter. Here, the
Sympathetic
thyroid
effects
stimulates
are also.
immunoglobulin,
Yes,
right?
sir.
The thyroid growth factors,
Okay,
right?
sir.
These are all if you consider it's an autoimmune disorder,
Yes, sir.
the highest spectrum is the Graves.
Yes, sir.
And the lowest spectrum is the Hashimoto's.
Okay, sir.
Both are having the similar features.
Autoimmune. Features, sir. Yes, sir.
The higher spectrum is the Graves.
Okay, sir.
Thereby, not only it involves the thyroid, that's why the difference between hyperthyroidism and thyrotoxicosis. Not only that the thyroid tissue, is involved, but it also
Extrathyroidal tissues are
the
also
other
involved.
target glands.
Yes, sir.
Right? That's why you get EPI, that is exophthalmics producing
Yes,
immunoglobulin. So the eye signs, the dermatological features are all more common in
primary
primary.
thyrotoxicosis.
Actually, in our medical books, they discuss all the three are primary only. The primary means the thyroid, it develops from the thyroid per se. Secondary is due to the other causes. When you
Yes.
take the Harrison's textbook, very clearly says, if you consider primary means, primary can be either a Graves' disease, it can be a toxic MNG, it can be a toxic nodule, or other features that involves the thyroid gland per se.
Okay, sir.
Whereas secondary means due to the other factors, maybe
Okay.
stroma ovary, something like that.
Yes, sir.
Right?
Yes, sir. Thank you, sir.
Thank you,
Yes,
Dr. Nikhil.
yeah,
Thank you,
Nikhil,
sir.
it is just that adding on to what Professor Kannan sir and everyone has said, that look at the type of the enlargement of the gland may be small, but remember every cell which you and I can't see. You
Yes.
understand what I'm telling?
Yes, sir.
So much acts, so much act, whatever be the reasons, whether it's a long-acting thyroid stimulator or whatever it is. So with the component of this autoimmune mechanisms, with the component of retrobulbar deposit, so that
Yes.
action of these cells to that extent of sympathomimetic activity takes place. So that is one of the very important causes for what the question which you asked.
Yes, sir.
Whereas if you look at a solitary nodule, you know the age group in which it occurs. And if you look at the multinodular goiter, you know very well that it is the internodular tissues often work rather than the nodule which is
Nodular tissues.
necrotic and most of the times. So
Yes,
you
sir.
know the amount of whatever hormone which is, I'm not trying to say that beyond 14 or 15 or 16 you call it, it is not like that.
Yes, sir.
That is one of the also important reasons, okay, for this so-called the manifestations of the hyperthyroidism is your thyrotoxicosis is at the cell level, every
Yes, sir.
part of the body. Okay.
Yes, sir.
Thank you, sir.
Thank you, sir.
Thank you, faculty. Thank you, Nikhil. You can
Thank
stay
you, sir.
back for the listening to the other two cases is going to be discussed.
Yes, sir.
Thanks to you, Professor Palam Praveen, sir, for permitting you to join this session today.
Thank you for the
So,
opportunity. Thank you, sir.
with the hyperthyroidism very elegantly discussed by the national faculty, now we move on to the next case. It's the case of carcinoma of the thyroid. To be presented by Dr. Anthony Eniga. Eniga, are you with us?
Yes, sir. I'm here, sir.
Okay, please switch on your video and share your PowerPoint. Dr. Vikas Singh, are you with us, sir? Right. Okay. Please introduce yourself, your unit chief, and then start your head of the department and start your presentation, Dr. Eniga.
Good evening, professors. I'm Dr. J. Anthony Niga from Tirunelveli Medical College. My unit chief is Dr. Babita Devi, ma'am. I'm going to present a case of thyroid swelling. Moving on to the history, a 20-year-old female patient came from Veeranallur with a chief complaint of swelling in front of neck for past 9 years. She also had a pain over the swelling for past 1 month. History of presenting illness, the patient was diagnosed as congenital hypothyroidism at the age of 3 months and she was started on thyroxine. She was on regular follow-up during which swelling in front of neck was noticed at the age of 2 years. At the age of 10 years, due to increase in size of the swelling, she underwent subtotal thyroidectomy as per history and started on thyroxine. 5 months from the surgery, she again developed swelling in front of the neck, more towards the right side of the neck, which was approximately 5 cross 5 centimeter in size. Patient was again reviewed with postoperative histopathological report, which was suggestive of intracystic papillary carcinoma in the background of dysarthrogenetic goiter. Patient also underwent the FNAC of the present swelling, which was suggestive of nodular goiter. Patient was then referred to higher center where histopathological slides were re-examined and which was reported as benign papillary hyperplasia. Since it was benign, they didn't underwent any procedure and they again asked her to follow up with thyroxine. Since patient also at present, for 1 month, she had history of pain over the swelling. Patient also had recent increase in size of the swelling for past 1 month. Since she had swelling for so long time, for 9 years, she doesn't have any increase in size, but for past 1 month, she had an increase in size of about 1 centimeter. No history of dyspnea, no history of dysphagia, no history of hoarseness of voice. History of menstrual abnormality was present in the past, but she's having regular cycle for past 1 year. No history suggestive of hyperthyroidism or hypothyroidism were elicited. No history of bone pain. No history of weight loss was present. No history of any other swelling was present. Past history, no other comorbidities like type 2 diabetes, hypertension, cardiac disease, seizure disorder, and asthma. No history of irradiation in childhood. Family history, her mother also had similar history of hypothyroidism, which was diagnosed when she presented, when this child was, when she was diagnosed at the childhood. And for that, she went thyroidectomy with records of which was not available. She's alive and healthy. Similar history of hypothyroidism is also present in her maternal side grandmothers. She had 3 siblings. No, none of them have history of thyroid swelling or similar complaints. Personal history, she consumes non-vegetarian diet, normal sleep and bladder habits, non-smoker and non-alcoholic. Menstrual history, attained menarche at the age of 14, regular cycle for past 1 year. Her last LMP was 22/11/24, 3/28 cycle, no clots. Summary, a 20-year-old female patient with history of hypothyroidism since 3 months of age with family history of hypothyroidism with history of subtotal thyroidectomy and recurrent thyroid swelling for past 9 years with history of pain over the swelling and recent increase in size for past 1 month.
So what is your conclusion by your history, madam?
Sir, she's having a long time history of swelling and hypothyroidism history, sir. With recent history of pain and increase in swelling, I am more on suspecting that there can be a malignant change, or she might have been also have a recurrence of that multinodular goiter again, sir.
Multinodular goiter. Recurrence of the multinodular goiter.
Yes, sir.
That's what you want to say, no? Please go to the first slide, madam. Next slide. Next slide, please. Why you ask history of dyspnea, dysphagia, hoarseness of voice?
So she's having a long history of swelling, sir. So I have to rule out any compressive syndrome she's having, and also I have to rule out any change recent. Since she's having recent history of increase in size and pain, I have to also rule out malignancy, sir. So any malignant infiltration can cause dyspnea and dysphagia, sir.
Okay. What are the grades of dyspnea? Do you know grades of dyspnea?
Yes, sir. There are 4 grades, sir. Dyspnea on sternus exercise, and last grade with the dyspnea on rest, sir.
Okay. You ask history of menstrual abnormality. Which menstrual abnormality you are suspecting in patient with thyroid swelling?
Sir, since she's having a history of hypothyroidism, I'm suspecting menorrhagia, sir.
Why?
And which, due to increased TSH, which is also an component of which mimic LH hormone, sir. So there might be stimulation and there be menorrhagia, and due to menorrhagia on long term, due to anemia, they will also have oligomenorrhea, sir.
Next slide, please, madam. There is no history suggest of hyperthyroidism and hypothyroidism.
At present, sir.
Huh?
At present, she's not having any symptoms of hypothyroidism, sir.
So which history you supposed to ask in patient to rule out hypothyroidism?
Such as cold tolerance, weight gain, normal appetite in spite of that weight gain. Then menstrual irregularities, sir.
Then
Uh,
what is the diagnostic sign of the hypothyroidism? Any clinical sign?
loss of angle reflex, sir.
Okay.
Decrease.
What is the difference between primary hyperthyrotoxicosis that from secondary thyrotoxicosis?
In primary thyrotoxicosis, the symptoms will be symptoms and the onset of swelling will be simultaneously, sir. And there will be more of eye signs and neurological symptoms. And in secondary, there will be an age, and in primary, it is in the younger age. And in secondary, it is in older age, sir. And there will be a preceding history of swelling followed by hyperthyroid symptoms. Usually in case of MNG, sir, they will be having associated cardiac conditions. So there will be cardiac symptoms also, sir.
Yes, there is no history of bone pain. Why?
So since I'm suspecting malignancy in her, I have to rule out malignant symptoms, such as bone pain, any bony swellings.
Which thyroid malignancy present as a bone pain?
Follicular thyroid, sir.
Follicular.
Okay.
Next slide, please. Past history. Why you ask history of irradiation to the neck?
Sir, history of irradiation in the neck can lead to papillary CA in adulthood, sir.
How radiation causes malignancy?
Sir, in irradiation, there will be
Mutation.
That can lead to a further mutation and can cause, sir.
You are specifically asked there is no history of irradiation to the neck in childhood. So
Yes, sir.
You irradiation to the neck previously?
In conditions like Hodgkin's lymphoma or for adenoids or any benign conditions like Akin vulgaris, she might have had, sir. Commonly with Hodgkin's lymphoma.
Presently, which is the condition there is after radiation, there is a development of the papillary carcinoma at present?
Adenoids, sir.
No, no. They are not giving irradiation to the adenoids at presently. Previously, they used to do irradiation for the benign condition.
Yes, sir. Lymphomas,
Okay.
mantle cell,
Non-Hodgkin's lymphoma.
non-Hodgkin.
Okay, Dr. Anthony, no? Doctor,
Yes, sir.
Anita.
just give me some idea about, because your history, both thyroid cases are interesting histories. Just tell me, what do you understand by congenital thyroid swelling? What do you understand by familial thyroid swelling? What do you understand by sporadic thyroid swelling? And what do you understand by endemic thyroid swelling? Because your case has got a lot of relevance for this every word. Tell me, why did you tell it is a congenital? First question.
Sir, congenital, it is present since birth, sir.
Accepted.
Patient
What may be the
present
reason
since
for
birth,
that?
sir.
What may be the reason in your case?
Sir, it can be endemic also. It can be due to
Just hold on, just hold on. Why did you tell suddenly endemic for a congenital swelling?
it can be due to dysharmonogenesis, sir.
So it can be due to
can be.
some abnormal development,
Development.
basically. You understand?
Yes.
It can be agenesis also, for that matter. Agenesis also. It can be abnormal development. Now, what did you understand by familial?
So familial, there is the swelling runs in the family, sir. But
So
it does not.
In your case, particularly, you should have put a better family tree. You understand, no?
Yes, sir.
For all of us who are sitting watching in this, you
Yes,
could
sir.
have put, that whatever, because some 3-4 members had, no? Correct?
Yes, sir. Her mother
So
had, and her father's mother also had, sir. Her grandmother
So
also
now,
had.
if you ask me that question, what is the age group in which father's mother had, and this child has? You understood, no? What age father's mother had?
Sir,
It's very important. Yes.
Her mother was diagnosed while she was 2 years old, sir. When she was diagnosed, only she was also diagnosed, sir. Until that, she was not aware of it.
See, what I'm trying to tell indirectly, because we can't fully explain, if mother has a CA breast at the age of 72, daughter has a CA breast around, say, 42, 45, 50, you cannot call it as a genetic involvement. I hope it's clear.
Yes, sir.
I just wanted to know whether these were also diagnosed when they're early age group.
No, sir, they were not diagnosed in the early age.
So now question comes. So these could be, do you think it's what is that malignancy which runs in families?
Medullary carcinoma, sir.
What is that?
Medullary carcinoma, thyroid.
So yes.
Men syndrome.
No. So just hold on. Medullary carcinoma, Men syndrome, which is the usual family gets affected. When I say it's not that common, in Indian setup, not that, Scandinavian countries. Okay. So if you see here, it can be a sporadic incident. Sporadic means once in a while. Now, I think what is endemic then? Because you started telling endemic.
Yes.
What is endemic?
Sir, it is confined to a geographical area, sir. If more than 5% of children below 12 years are diagnosed with thyroid swelling.
So yes, very good. In your particular case, expect all these questions, and you have to be very clear about this, because 4 family members, including father, you said some, correct? They also had
father's mother, sir. Father didn't have any comment.
So that is also there. So in other words, so you have to really find out if possible. See, they may not tell you the history, but examiners will expect you to have a clarity on congenital, familial, of course, dysharmonogenesis. You said something about that, no? Dysharmonogenesis. What is that?
So
What
it
is
is
that hormone?
Thyroid. It is an enzyme deficiency in which are involved in thyroid synthesis, sir. Due to this, there will be decreased hormone synthesis since birth. So they may present at congenital.
Usually
Peroxidase.
So,
Usually peroxidase.
So you have to have a clarity on these issues. Pendred syndrome, you heard of that? So few of
Yes,
the
sir.
things you should know. Okay, so have a clarity on this, especially in your case. So you have already, there's a diagnosis in your case, correct?
Yes, sir.
Diagnosis of malignancy is there. Yes or no?
Yes, sir.
Yes.
But she had a diagnosis of malignancy, sir.
Yes.
For which she was referred, but they reviewed her slides, sir. In that, it was only hyperplasia. It was not malignancy.
Yeah, but then you will have a doubt there, no? So
Yes, sir.
whether there was something else has been done. Okay, please continue.
Dr. Eriga,
Yes,
you
sir.
are talking about the dysharmonogenesis, no?
Yes, sir.
So have you asked for any, deafness in the patient?
No, sir. There was no deafness, sir.
You have to identify that because in Pendred
Yes, sir.
syndrome,
Pendred.
due to the peroxidase deficiency, there will be sensory neural deafness also, right?
Okay. Yes.
Any other dysharmonogenesis, other than these Pendreds? Dehalogenase deficiency.
Okay.
The two dysharmonogenic types are, one is the Pendreds, another is the dehalogenase deficiency, right? Okay, it's a very interesting thing. How do you diagnose, this congenital hypothyroidism?
So she from history, she said that she's taking thyroxine, sir. Then
So
also
little
she
bit
had on.
inquired about how, when they diagnosed it, how they
So
diagnosed it.
she had history of constipation at 1 month of age, sir. For
Yeah.
which only she was admitted. During that evaluation only, they found out that she's having hypothyroidism.
It's a very interesting, finding you're telling, no, that you should have told earlier itself, right? So that would have given us a good idea about how she was diagnosed having this congenital hypothyroidism, right? Oh, to the clinical examination.
General examination, patient is conscious oriented afebrile, moderately built and nourished, no pallor, no pedal edema, no generalized lymphadenopathy was present, no eye signs was present, sir. Her vitals was stable, pulse was 82 per minute, normal in rhythm and volume, sir. An examination of neck, after getting consent with adequate exposure in well-lit room, patient examined in sitting room with neck in slight extension, myself standing in front of the patient, a single swelling of size 6 x 7 centimeter in the thyroid region, 2 centimeter above sternal notch inferiorly and laterally 2 centimeter medial to the anterior border of right sternocleidomastoid and 5 centimeter from the anterior border of left sternocleidomastoid and superiorly up to the thyroid cartilage was present, which was irregular in shape, smooth surface, and the borders were well defined. A scar of size 5 centimeter was present, which was healthy. Lower border visible, moves with the swelling moves with regulation, does not move with protrusion of tongue. Plane of swelling was deep to deep fascia, no other visible swelling. Trachea appears to be in midline, and the oral cavity, she had multiple tooth decays. On palpation, patient examined in sitting position with neck in slight flexion, myself standing behind of the patient. Inspectory findings were confirmed. 2 nodules palpable at the thyroid region. Largest was 4 x 4 centimeter. Surface was nodular, firm in consistency, well-defined border, and it was mobile. Tenderness present on palpation over the gland. Trachea shifted to the left. No palpable neck nodes and bilateral carotid pulsations were present. Oral cavity, no other significant findings. A systemic examination was normal. Diagnosis, a case of recurrent multinodular goiter in euthyroid state, probably malignant with no complications.
Why do you consider it is probably malignant in your clinical presentation?
So she's having a long history, and from history, she's saying recent increase in size, and there is pain associated with that, sir. And in
can you get in a benign condition where sudden increase in size and pain?
Yes, sir. Due to hemorrhage, in multinodular goiter also you can get, sir.
Yeah, you can
that
get
is one of my differential diagnoses, sir.
Okay.
What are the levels of nodes you will examine in this case?
Sir, in thyroid, usually level 6 and 7 are involved, sir. Lateral neck nodes, level 2, 3, and 4 are examined, sir.
4 and
Posterior
5.
triangle.
Which group you will examine, 5A or B?
Okay.
So you have to lateral nodes, you have to examine. Central nodes, can you, if it's enlarged only, you can.
You can examine.
Otherwise, it is not possible to identify clinically, right?
Yes, sir.
Doctor, what will you do for this case then?
Sir, I will do an quadruple assessment, sir. After history, I will proceed with the biochemical analysis. I will do TFT. Then I will proceed with UHG, sir. UHG and confirm whether what type of swelling it is. And if she is in euthyroid state, I will proceed with the FNAC, sir.
In ultrasound, what exactly you want to see in this patient?
Sir, we have to see malignant features, sir. Taller than wider, hypoechogenicity, how the margin is, and how the vascularity is. And we have to differentiate it between benign and malignant, sir.
Okay. When can ultrasound really differentiates between the benign and malignant lesions?
Yes, sir, to somewhat through TRADS grading, we can.
So there is some
have
grading. What is that?
TRADS grading, sir.
And what is that?
Therapy.
What are the probabilities? So suppose say what ultrasonological finding will suggest more in favor of malignancy? What are the features which suggest more in favor of benign?
Sir, ultrasound features such as hypoechogenicity,
Right.
taller than wider,
Mm.
internal echoes, and
Mm.
irregular margins, sir.
Mm. So basically, if there is a hypogenicity, there are more chances, isn't it?
Of malignancy.
And there is pure hyperechogenicity also you have to think. If it is taller than wide, you have to think. If there is a associated lymph node, then which is taller than wide, then you have to think about malignancy. Because in this patient, there is a confusion. So you have to be very careful from the non-invasive investigations to the histopathological examination, cytological examination. See, already cytological examination was, there was a difference of opinion from one institute to other institute as per your history, isn't
Yes,
it?
sir. Yes, sir.
So you have to be very careful about non-invasive investigations also. Is there any role of CT scan in this patient?
Yes, sir. Since it is a recurrent, we have to go on with CT, sir. And there is already an discordance between in FNAC, sir. So definitely we have to do CT, sir.
What
And
are the CT findings which suggest malignancy?
In CT also there is heterogenicity, infiltration to the surrounding tissue, sir. No presence of cervical nodes.
Presence and absence of the cervical lymph node and its character. Is there any central necrosis? All those things can be very well described by the CT scan. And also if there is a retrotracheal and retrolaryngeal extensions. These are all signs of malignancy. If it is crossing beyond the planes. If it is crossing beyond the planes, that means there is infiltration. If they are crossing the planes, then you have to think about if there is any infiltration into the strap muscles. Or whenever it is crossing the planes, then you have to think about the malignancy. You have to do a CT scan in this patient. Any large swelling, you have to take a CT scan. It will tell well about the position of the vessels, trachea, and is there any retrosternal and retrotracheal extension. All these features will help you in the surgery as well as making a clinical diagnosis of the malignancy or to exclude malignancy, isn't it? So now nextly, after doing all these things, now already FNAC you have already done. Now what do you want to do in this patient? What kind of FNAC you will advise?
So preferably USG guided FNAC, sir.
USG guided FNAC. Preferably from where? You have to USG wherever ultrasound shows any hypoechoic area or hyperechoic area, that particular area you have to guide. Previously they have given, I have gone through your slides. Previously it was given, the second institute has given as hyperplasia of the papillary cells. That is what they
Papillary.
say. So
Yes.
one thing one should remember: if there is a papillary hyperplasia, unless there is malignancy. See,
Yes.
the papillary carcinoma of the thyroid is very easy to diagnose on FNAC. What are the other malignancies which can be easily diagnosed by FNAC?
Anaplastic, sir.
One is papillary carcinoma, anaplastic carcinoma,
Anaplastic. Fertile cell.
lymphoma, and these malignancies are easily diagnosed. Whereas follicular malignancy, you cannot diagnose because
We
it
cannot
requires
diagnose
capsular
that.
and vascular invasion, as we have already
Medullary carcinoma also we can say.
Medullary carcinoma is also you can diagnose. Okay. So in this patient now you will do a FNAC. Now what exactly you want to, you will talk to you about your pathologist now.
So
Now
I have
that
to,
one institute has given papillary carcinoma, another institute, another pathologist has told it as hyperplasia of the papillary cells. Now you are doing another FNAC in your institute. Now what do you want to talk to? You want to communicate with the pathologist. Now what do you want to
yes,
speak to pathologist?
I have to say detailed history to her, sir. Like that she had previous histories also. Then as per history, after she again had one FNAC, sir, in between, which was nodular goiter. So that only she was kept on follow-up. That history I have to say her. And that papillary, since she had papillary hyperplasia, I have to mention it specifically and ask her to check, sir.
Okay, once again, now pathologist says that I am seeing a lot of papillary cells. Papillary pattern is seen.
Yes,
but then she says that it is a papillary pattern. What will you say?
So, she's seeing papillary, then what's it?
She says, once again, I am seeing papillary pattern in whatever cytological cells I have stained. I am seeing, once again, a lot of papillary cells I am seeing, but she is also a little confused because previous institute said hyperplasia of the papillary cells.
Then we have to go for definite biopsy, sir. We can proceed with completion thyroidectomy of that.
No. Before going to this major invasive procedure, see what exactly you can do with the pathologist. One thing is when there is a papillary pattern is seen, you have to think of papillary carcinoma. One. You have to see whether it is a micropapillary carcinoma. It basically depends on the size of the tumor. And second thing is, can you ask for any molecular markers?
Yes.
You have to ask for the molecular markers. They will tell you whether it is malignancy or not. Okay.
Okay.
Suppose if it comes as a malignancy, what will you do?
Sir, if it comes with malignancy, we can proceed with completion thyroidectomy, sir. We have to proceed with thyroidectomy.
You want to go for total thyroidectomy. In between, I was not following you. I was in a car. So this patient had hemithyroidectomy before.
Subtotal thyroidectomy.
Subtotal thyroidectomy. Okay. Yes. Then now you want to, is it going for total thyroidectomy? Is it difficult in this case or easy in this case?
It is difficult, sir.
So what will you counsel? What is the difficulties you will see in after subtotal thyroidectomy? You are going for total thyroidectomy. Now, what difficulties you actually face?
There is more creating plane is difficult, sir, and there is more risk of nerve injury, sir. So we have to pre-up.
Right.
Pre-operatively, you have to counsel the patient, sir, and explain the risk of nerve injury.
Then what is other injury? Hypothyroid is hypoparathyroidism.
Hypoparathyroid.
Injury to parathyroid glands, injury to the recurrent laryngeal nerves. Both are very high chances of injury to these two structures in this patient. So during surgery, anything additional thing you want to take extra precaution you can take in this patient?
For nerve, we can keep nerve monitor, interrupt nerve monitoring.
You have to in these group of patients, nerve monitoring helps a lot.
Yes.
We routinely don't use nerve monitoring. We have recently attended 2-3 workshops. We in our institute also we routinely do not use nerve monitor, but I felt it is very useful, especially these kind of patients. Okay.
The doctor,
yes, sir.
This patient had a 6 into 6 centimeter swelling, as you are discussing here.
Yes.
The features of a cystic swelling, intracystic malignancy. What type of malignancy you will get when there is a cyst with a malignancy?
Papillary carcinoma, sir.
Yeah. So that is the most common thing,
Common.
right?
Yes.
Then what is Lindsay tumor?
So it is an follicular variant of papillary carcinoma. Sir.
So in a hypothyroidism,
So
multinodular goiter, more prone for follicular.
follicular.
Right? But you can get a papillary pattern also.
Histopathologically, it will be papillary. Sir.
Could be even a Lindsay also, right?
Yes.
Histologically. But clinically, when the patient has a cyst and a malignancy is suspected in a cyst, you have to think of papillary carcinoma, right?
Yes.
Doctor, I have just a few questions only. Suppose if you were not to have any report available with you,
Yes, sir.
what you would have thought of? First question.
Sir,
From the time of surgery, she's born, and then sometimes
I
you
would
said
have thought of medullary, sir. But from her family history, I'm sure that it is not medullary, sir. Because at her age of presentation and she underwent surgery at the age of 10, it is more of medullary-like features. But her family history, she's saying that they have long history of hypothyroidism and they are taking drugs and none of them had an history of malignancy or something, sir. And by history also, patient says that they were assured that it was not malignancy.
okay,
So
I just
am
want
not-
to, basically, I would like to drive a important that what are the peculiar presentations of papillary carcinoma thyroid? You just tell that. So that it will take back to your few things compared to follicular or medullary or obviously anaplastic. Yes, tell me.
What, sir?
What are the peculiar, what I'm trying to tell is a little unusual presentations of papillary carcinoma thyroid in general. Forget about
So
this patient.
she might have got thyroglossal cyst, sir, which might have.
No, let us not go to thyroglossal cyst and developing malignancy. What I would like to tell is a younger age group presentation. I said
Sir,
general
genetic
presentation.
mutation, sir. It can be associated with FAP.
No. What I'm trying to tell is anything is possible. What I'm trying to tell is forget about for the timing. I said general. So occult primary with only the lymph node enlargement. Lymph nodes can be soft. We all know that hard means only malignancy. Lymph nodes can be softer. It can be firmer. It can be harder. Younger the patient, good prognosis. Elderly, yes. And then what else? They rarely come out, breathe the capsule. Slow growing, having good prognosis. So longer duration. So just because somebody has a neck node here for 2 years duration, you can't rule out a papillary carcinoma thyroid. Is it clear to you?
Yes, sir.
Have you understood my question?
No, sir.
Not really.
Yes, sir.
So what I was trying to tell is just go through it. Most common malignancy, papillary carcinoma, is a very, very unusual behaviors, and also younger age group, child, adult, old age. In fact, it behaves more aggressively than younger. Occult primary, soft, hard, firm, most of the time intracapsular, rarely breaks out. So having an excellent prognosis. So there are many things about the papillary carcinoma thyroid. Okay, right.
What sir want to tell you is not only a thyroid swelling, you can get a nodular swelling.
Lateral aberrant thyroid.
Yeah, they used to say, no, there is a,
Yes.
what is that node called as? When you have a single node.
Lateral aberrant.
Not lateral aberrant thyroid. When you have a prelaryngeal node.
Delphian node.
Delphian node.
No.
So you can have a soft node. That's what. A bluish node,
Yes.
When you do surgery, when you see a bluish node, it's usually a papillary CA. Right? Soft node.
Yes, sir, agreed. Papillae are so thin, so little bit of hemorrhage and that, little bluish discoloration, very well known. And as a postgraduate, if this question is asked to you, any other things where melanoma, I'm not trying to say your case or something, when you open that's obviously a pigment, not necessarily a bluish color, but just to keep you, when you open a inguinal area, sometimes, somebody comes with a nodal swelling, you open it, it's little, suspicious. So just, you might have missed the examination limb. Just thank you, sir.
What is the, doctor, what is the importance, what is the peculiarity of these lymph nodes? What is the characteristic features of these lymph nodes, especially in papillary carcinoma thyroid? And another hint, how they are helpful in future treatment?
Sir, as I said, it can be soft in consistency also, sir. Based on treatment in papillary CA, if
No,
you're
my
having...
question is not that. Anyway, we are running short of time. These nodes are functional. They are functional.
Yes, they can also secrete. They
are functional in nature. So, see, their function is much lower grade when compared to the thyroid. So, if you do a total thyroidectomy, if there is any recurrence, these lymph nodes and metastasis are functional. So, if you can treat it with radioiodine ablation. So, these character helps in managing the post-operative period in case of recurrence or follow-up, all those things. So you should know the point that the lymph nodes are functional in nature. They secrete. That is the reason there are two important points. That is why we give thyroxine suppression, TSH suppression, and this help in utilization of radioactive iodine. These two things. There is a reason we do total thyroidectomy.
Yes.
When you've done the total thyroidectomy, how do you follow your patient?
Sir, I have to follow with the histopathological report, sir. Based on which, if it is, I have to look for size.
Comes out as a papillary carcinoma. Okay. Then how
if
do
it
you
is
follow?
If it is papillary carcinoma, I have to assess the risk, sir. Whether she falls into intermediate or high risk group. If she falls within that, then I have to proceed with radioactive uptake scan, and if there is uptake, I have to proceed with ablation, sir.
When you will do the scanning?
Sir, if she falls into a high risk category, such as if there is margin positive, extranodal extension was there, and the large size of tumor more than 4 centimeter, then I will proceed with the radioactive uptake scan, sir. In that, if there can be
when you will do that? When you will do the scanning?
After 4 weeks, sir, because the requirement is TSH must be more than 30, sir.
Yes.
So I have to wait for 4 weeks. I should not start the patient on thyroxine, sir. For the TSH should rise, I will wait, and then if the TSH is adequate, I will proceed with the scan, sir.
Okay.
If he says that I can't wait for 4 weeks,
then I will substitute with recombinant thyropoietin injections at 0.9 international units. 2 doses we have to give. On the 3rd day, we can take the scan, sir.
when you are sure there is margin is not positive, and why do you want to do the radioactive scan?
So that can be microcapsular extension also.
No, you are sure that you are saying that already there is there. Positivity is there.
Margin
can you
positive.
go directly with an ablation instead of waiting for an uptake scan and then again once more going for an ablation?
Sir, I have to rule out other sites where there is uptake, no, sir. Whether it is
which site?
Metastatic or not.
Where?
In the nodes, in the other regions such as liver, lung, and in the bone, sir.
So thyroid you are going to get in liver and lung.
Sir, metastatic is commonly to lungs, sir.
Which malignancy metastasis to lung is common? In which thyroid malignancy?
Follicular.
So commonly you see lymph nodal metastasis in papillary carcinoma.
Papillary carcinoma.
Papillary carcinoma.
What is the role of thyroglobulin assay?
I said it helps us in follow-up, sir. After ablation, we have to follow up with the thyroglobulin, sir. if it is raised, then we have to do again. We have to do uptake study and see whether there is any recurrence or remnant.
See, there are two things. Preoperatively, you have to assess thyroglobulin. That is one.
Yes, sir.
See, and what happens to thyroglobulin level after surgery? Two, and then follow up, isn't it?
Yes. Okay.
In some of the cancers, so thyroglobulin may not be elevated. In some of the cancer, thyroglobulin is elevated much, isn't it? So this
Yes.
thyroglobulin is, if it is there preoperatively, that sounds a better follow-up tool, isn't it? And see, you are talking about radio ablation, isn't it? Will you give
Yes.
ablation to all patients?
No, sir. For low risk category in micropapillary conditions, it is not needed.
Micropapillary condition is, it is not very common. It is rare. We talk about pure carcinomas. You told no, you told certain things when there is extension into the surrounding
Extension.
structures, all
Yes,
those
sir.
things,
If
you will
they
give
are not,
ablation. See, in ablation, the routine, whatever the ablation, the people you give ablation, they'll give two types. One is low grade ablation. Second one is low dose ablation and high dose ablation.
right.
High dose ablation. See,
Yes,
high
sir.
dose ablation requires isolation. Low dose ablation doesn't require much isolation.
I said it.
In most of the institutes, only in very few institutes or where isolation facilities are there, you give high ablation. Whenever there is high risk factors, you have to give high dose ablation. Whenever there are low risk factors and the surgeon is not experienced, then you have to give a low dose ablation to the tumor bed. That is how they follow.
Okay, sir.
Suppose your thyroglobulin level is increasing, but your uptake scan is negative.
Yes, sir. Sir, it is a different entity called tennis, sir. In that cases, it is commonly due to inadequate preparation, sir. Patient may have increased iodine content, sir. So we have to reassure that whether patient had adequate iodine deficient diet, something, and then we have to proceed, sir.
Again with the thyroid, again with the iodine, you will do that, or you have any other method?
Then we have to do PET scan, sir, for that patients.
So why the PET is taken up but not the iodine? Is what is the problem there? Pathogenesis.
There may be D-differentiation, sir.
Okay, one is D-differentiation.
Differentiation.
And the sodium, but this iodine importer will be not functioning. But it will be taking up the PET scan will be positive.
Positive.
Suppose it is a positive in the bone, will it be a cold nodule or a hot nodule?
Hot nodule.
Hot nodule. Good. Because when it is going by secondary, the nodule is you are going to decide with the surrounding radiation. So in the bone, it will be always, or when they are going to the secondary, it will be a hot nodule, not a cold nodule. Suppose during surgery, if you see the recurrent nerve, there is a bit of tissue is there, you are not able to remove it fully. What do you do?
So if there is chance of injury, we can leave, sir, because we can take care with the remnant ablation, sir.
So there is no need to go for cutting it.
Yes, sir. We can preserve.
Sir, send a message. Okay.
Faculty, any other faculty would like to give their comments or questions, please? Kanan, sir?
Well presented, but you have to think about the de-differentiation of a differentiated thyroid malignancy. No, whenever the patient is having a sudden increase in size, right?
Yes, yes,
and then which is behaving because this papillary carcinoma is a slow growing malignancy and doesn't cause much problem for it has varied presentation, but a sudden increase in size in a patient who happen to have a occult or a micropapillary CA, we have to rule out de-differentiated malignancy. That is anaplastic change, right?
Yes.
And also, you should know that, doctor, that pain is very, very not at all a feature of a thyroid swelling, because rarely we get thyroid abscess, or we are not discussing acute or subacute thyroiditis here. The one other thing is that lymphocytic thyroiditis. So you should look at the background. Like I have asked you this question: congenital, sporadic, endemic, familial, especially your case. So this lymphocytic thyroiditis may turn also into malignancy. You also should keep that in mind when the pain is a new symptom, which you are especially you are talking about this patient, no?
Yes,
Here.
sir.
Otherwise, see, without any clinical features, you cannot say that it is a malignancy,
Yes.
at least from the diagnostic angle. Yes, recurrent goiter, most probably multinodular goiter. Yes, euthyroid state you are written. Probably you are written probably malignant. What was the reason for that?
It was a recent increase in size and pain only, sir.
Because remember one thing, thyroids enlarge as the child grows. You know that, no?
Yes.
Correct? So
Yes.
puberty, even lingual thyroid for that matter, even any other ectopic thyroid tissues, remember, they grow. It may be present like a very small thing, but as the child grows, it also grows. It is the typical hyperplasic goiter. You understood, no?
Yes, sir, I understand. Yes.
Thank you.
One thing about calcification, ma. If it is a
Yes.
papillary CA, what type of calcification you will have?
Dystrophy calcification, sir. Some of my bodies.
Yeah, is it fine or a coarse calcification?
Coarse calcification, sir.
Is it so?
I'm not sure, sir.
See, there are two types of calcification: fine stippled calcification, coarse calcification. No,
Yes, sir.
fine stippled means always dangerous. Whereas in some cases where you can have a dystrophic calcification, when you have a larger calcification, they used to say it's a thyroid stone, right? But remember, these cases are all malignant only, right?
Okay. Okay.
Dystrophic calcification in thyroid, which is like a stone, no?
Yes.
Always you have to rule out malignancy, especially the anaplastic.
Okay, sir.
Rim calcification.
Sir?
Have you heard that rim calcification?
Something like that.
Entire lobe will be the border will be calcified. Is it benign or
Yes, sir.
malignant?
Benign, sir. It can be seen in multinodular goiter.
When it will be called as a malignant, rim calcification with breakdown, or when it is
Okay.
in between there is a growth is coming out or it is ruptured, then it is more in favor of a malignancy.
Malignancy.
So thank you, faculty. Now, Eniga, do you have any doubts to be clarified with the national faculty here?
Sir, I have one doubt, sir. If in case of after in such conditions, if in older age, if she's gonna get pregnant, what are the precautions? What are the advice, and how we have to manage her during that time, sir?
That is a long question now.
Because I referred books, sir. In nothing, I could find a definite criteria like that, sir.
No problem. See, please understand. There are definitive ATA guidelines for planning pregnancy and others after total thyroidectomy, after radioactive iodine ablation, and people who are on anti-thyroid medicines, ATMs they are called.
Okay.
So anti-thyroid medicines have to be obviously titrated depending on to the requirement of pregnancy, a minimum of 3 months in advance. That is a recommendation now.
Sir,
Then
I
it has
also,
to, sorry?
sir, I read that during pregnancy there will be raise in TSH so that we can give lower dose compared to what she's actually taking. Is that so, sir?
No. The point is, first of all, the drugs your choice are limited with during pregnancy or 1 or 2 only.
Okay,
All right.
sir.
Then
Okay.
there are definitely very clear ATA guidelines which says what happens to the women who have been treated for malignancy. See, even now the world is heading towards conservative thyroid procedures for papillary thyroid carcinomas. right?
sir. Yes,
So
sir.
they have a different, very clearly laid out policy by the AT, American Thyroid Association, for
Okay.
people who have malignancy and remnant thyroids, people who have been treated for malignancies and who have got total thyroidectomy done, and people who have been treated for Graves. These are the three major things we are concerned about pregnancy: hyperthyroid state, athyroid state, and the people who are on various type of suppression drugs. These are the three categories you should be segregated, but there are
Okay.
very clear algorithms. Okay, I will
Okay,
try
sir.
to
I'll
send
check.
you the guideline to you, to your WhatsApp number. Any other
Thank you,
questions
sir.
you have?
No, sir. Thank you, sir.
I think just to tell you that there's no contraindication to have a pregnancy, just for your information, because if
Yes, sir.
the patient is young and is, you know that most of them, if you have done a good job and she's on thyroxine, and if they want to conceive, you need to obviously take care of the many things there, but there is no, you can't say that, don't have pregnancy. No.
Okay, sir.
Usually it is 6 months or maximum the 12 months only that time. After that, you will have the normal growth and there will not be any contraindication. In fact, the
Okay.
first 6 months we are trying to avoid, and the 6 to 12 is one area where you can be careful. But otherwise, there is absolutely there is no contraindication for getting a baby.
Okay, sir. Thank you, sir.
Okay, nice presentation, Amma. Bye.
Thank you,
Thank
sir.
you, Dr. Thank you, Dr. Enika. Thanks to Professor
Thank you.
Babita ma'am for permitting you to join this session today. Now we have Dr. Sailesh. Sailesh is kindly contributed by Professor Aparna Deshpande ma'am from KM Hospital and the Sage GS Medical College, Mumbai. So he is going to share his presentation on mass abdomen. Sailesh, please introduce your unit chief, head of the department, and then start your presentation. Good luck to you. Faculty, please take over. Can I make it full screen, ma? We are unable to hear you, Dr. Sailesh, for some reason. Are you using headset or something? We are able to see you well. Your PowerPoint is seen, but we are unable to hear you. Can you quickly log out and log in now? Switch off all the associated Bluetooths or any pinned in headsets or something. Or just reset the speaker button. No? Can you do that on the top of the Zoom?
Hello, am I
Try
audible
speaking now.
Am I audible now?
Yes, now only you are audible.
Yes.
Yes, yes. You are good to go.
Yes, sir.
Good luck.
Yes, sir. Thank you, sir. Greetings, everyone. Myself, Dr. Shailesh Ade, Resident General Surgery, KM Hospital, Mumbai. I will be presenting a case on abdominal lump under the guidance of Dr. Aparna Deshpande, Head of Unit General Surgery, KM Hospital, Mumbai. 45-year-old female case, resident of Uttar Pradesh, housewife by occupation, having no comorbidities, came with complaint of abdominal pain since 1 year and abdominal lump since 5 months. Patient was apparently all right 1 year ago when she started developing dull aching abdominal pain in the left hypochondriac region and epigastric region. Insidious onset, gradually progressive, non-radiating, not related to food intake, relieved with medications. Patient started developing abdominal lump in the same region, insidious onset, gradually progressive, associated with mild pain and discomfort. Patient also complaining of nausea and anorexia. There is no history of yellowish discoloration of eyes, urine, and stools. There is no history of fever with chills. There is no history of significant weight loss. There is no history of altered bowel habits. There is no history of hematemesis melena. No history of prolonged use of OC pills. There is no history of chronic NSAID injections. No history of early satiety. No history of COX or COX contact. There is past history of similar complaints. Undergone open hydrated cyst excision in 1994. Details are not available, sir. And she consumes mixed diet, housewife by occupation, resides in rural area. Based on the above history, it can be the lesions originating from the liver and stomach. Shall I proceed, sir?
No, for the liver and the stomach, that is okay. But just, that because we don't know the type of the acceptance from the different examiners. So
Yes,
just
sir.
to give you, first slide itself, you started telling epigastrium and left hypochondrium.
Yes, sir.
Preferably, just because again, clinicals, there could be a difference of opinions. I'm agreeing with that. Upper abdomen is definitely better.
Yes,
So
sir.
you know that a female with upper abdomen definitely more on the left side. So when it is more on the left side, your mind automatically thinks certain organs. So
Yes.
keep that progress in the mind. You are written not ready to the back. All that is fine. So
Yes.
in the negative history, you started first itself with the yellowish discoloration, eyes, urine, stool. Why is that?
Because there is no involvement of biliary tract, we can rule out that.
No. That's the question which. So what is that you had in mind? If this question is asked to you,
There is no compressive symptoms.
where
That tumor.
left hypochondrium and left epigastrium you were telling, na?
Yes, sir.
So is it common?
No, not so common, sir.
When do you expect this question? Yellowish discoloration, which you have written there, clay colored stools or whatever. It's more of hepatobiliary, more
Yes,
on the
sir.
right. You only state compression.
Yes,
Yes,
sir.
what's the intention of fever and chills for this patient?
That there is no infective foci of infection such as
1 year duration, na? 1
Yes,
year
sir.
duration. So 1 year duration, what we are interested is slow progress, enlarging. So GIT is not much of GIT symptom. Any GIT symptoms? Any GIT
No.
symptoms your patient
No,
has
sir.
got?
No, sir.
Nothing. Hepatobiliary is more for the right side. So left area, that is the side. Endemic areas. What's the importance of fever and chills and rigors?
It can be present in infective conditions and in cholangitic patients. They can present with fever, with chills.
Again, don't miss the, don't miss the. See, we are not talking about cholangitis now. See, please remember, you think your patient.
Yes, sir.
We are talking about the left side. So
Yes.
suppose you have got a big spleen. It's possible.
Yes.
This patient, I don't know. This patient may be having a big spleen.
Yes.
Correct? 1 year duration. So whether it's a chronic malarial spleen, nowadays you don't get it. Portal hypertension, whatever, leukemias, whatever it is. See, don't suddenly bring the word cholangitis now. Female
Yes.
patient, urinary tract infection is more common. So you understand when this question is asked.
Yeah.
Your mind should work in that direction. Right?
Yes.
So what's the purpose of asking the hematemesis melena if this question is asked? What do you say?
That there is no pancreatic involvement or periampullary involvement.
Please remember, it is hematemesis and melena, and there's no jaundice. I mentioned to you left hypochondrium and epigastrium. As per your statement only, I'm telling. I just wanted you to remember portal hypertension. You understand, no?
Okay.
See, mind don't get biased with the diagnosis. Obviously, so you know that you are in the left epigastrium, can be liver, can be spleen, can be tail of the pancreas. So your mind should have a broader working on that. Okay, sir.
Shall I proceed, sir?
What is that prolonged OCP and what you are looking at?
The hepatic
What is
lesion,
it?
hepatic adenoma can be associated with the use of OC pills in females, sir, in this age
What
group.
is that prolonged use means? What?
Oral contraceptive pills, sir.
No, OCV, no.
Yeah.
How do you quantify that prolonged use? Is it a dose specific and a duration specific?
The duration specific.
Is it? Oh. So it produce any without that OCP, any carcinoma can come?
Yes, sir.
What type of carcinoma we get?
In this particular patient?
Yes, if it is you're thinking in terms of carcinoma from the liver, because we are thinking of a lesion from the liver, no?
Yes, sir.
Okay. Which has no cirrhosis, no the OCP pills history, nothing will be there. Young age. Have you heard the term fibrolamellar carcinoma?
Okay, sir. Yes.
Go ahead.
Physical examination. Patient examined in supine position in a well-lit room, adequately exposed from nipple to knee. Consent taken. Patient is conscious, cooperative, well-oriented to time, place, person, moderately built. Vitally stable, febrile, respiratory examination, air entry bilateral equal, no pallor, icterus, generalized lymphadenopathy, clubbing, cyanosis. Abdominal examination, inspection. There is no evidence of obvious fullness in any quadrant.
Examination, have you looked for any nutritional changes?
No, sir.
Any other features of liver disorders or
no, sir.
dysfunction?
No, sir.
But this is like an undergraduate presentation. You are putting all that is what is saying in all cases. You are particularly now examining a case of liver, and what specifically you are going to look for that?
That patient is conscious, cooperative. There is a nutritionally she's not adequately built. There are no signs of pallor, icterus.
Pallor, icterus, liver dysfunctions, the stigma of the chronic liver.
No, there are no stigmata of chronic liver diseases.
Okay, little more you must be, because postgraduates little more specific for the case which you are going to look, not the routine generalized lymphadenopathy, clubbing, cyanosis. Why do you want to look for cyanosis here in your case?
Peripheral cyanosis.
For what reason? You are but the liver producing peripheral cyanosis?
No, sir. It's general examination. Not.
For what reason? But what you are going to look for that? What do you want to look for that? It is not a routine. General examination is not just what is routine. In your case, what you are going to specifically look with the history you have taken a conclusion, and what is the system you are involved in relation to that system that you are going to ask the questions.
Yes.
Okay, go ahead.
On examination, on inspection, there is no evidence of obvious fullness in any quadrants of the abdomen. There is no evidence of obvious fullness in the flanks. Umbilicus was central and inverted. There is evidence of previous surgery scars, transverse scars noted above the umbilicus of approximator length 18 centimeter. There is no visible peristalsis, no generalized abdominal distension, and hernial orifices are intact. On palpation, abdomen is soft, mild tenderness on deep palpation in the epigastric and left hypochondriac region. There is no guarding rigidity. On superficial palpation, there was no local rise of temperature. Mass is palpated in left hypochondrium extending to epigastrium. Size of around 10 by 8 centimeter, rounded, smooth, firm consistency, non-mobile, moves slightly with respiration. Upper border not palpable, lower border is palpable. And right side of liver is not palpable, and there are no obvious pulsations. This is my patient having transverse scar noted above the umbilicus of previous surgery that undergone hydrated cyst excision in 1994 along with splenectomy. And on palpation, there was lump felt over the left hypochondriac and extending to epigastric region. On head and leg raising test, their swelling was reducible in size, suggestive of intra-abdominal swelling, and knee elbow test, that is rarely done, but swelling is prominent, that is intraperitoneal swelling. On percussion, swelling produced dull note on percussion, and there was no evidence of free fluid in the abdomen, and puddle sign and shifting dullness was negative. Auscultation, there was normal bowel sounds heard, no audible brood. Per rectal examination was normal. Systemic examination was also normal. CVS S1, S2 heard, CNS no focal neurological deficit. Provisional diagnosis: 45-year-old female complaining of gradual onset pain in the left hypochondriac and epigastric region with palpatory mass without any history of jaundice, fever, significant weight loss, suggestive of benign liver lesions, likely hepatic hydatid cyst, cystic neoplasm of liver, or solid liver lesions. My differentials are liver lesions that were enumerated, and the gastric lesions, pancreatic lesions, lymphoma that are less likely.
Can you elaborate on the surgery done previously?
Sir, there were no details available, but we got to do that. It was open surgery with hydatid cyst excision along with splenectomy, sir. in 1994 when she was 20 years old.
Where was the hydrated cyst?
In liver only, left lobe, sir, and left lobe of liver.
No, why spleen is also taken?
Sir, the details not available. We are suspecting maybe there were splenic cyst also, but details are not available.
So do you feel that 94 where she underwent the surgery and this incision, how old is she now?
45 years.
What was her age that time?
20 years.
So 20 years. So from look at the incision. Is it what type of incision is that?
Transverse incision.
Correct, no? If I'm
line.
so, what you would have preferred? Suppose I ask you this question.
Yeah.
What probably you would have preferred? Just a simple. I don't know what was the ultrasound finding. What is the that time 94 probably ultrasound was there definitely. So CT also. I'm not sure, but just your opinion.
Do you normally through and through like a big incision like this, or when a left lobe of the liver to reach? Do you
subcostal incision would be better?
Options. Yes. One is a subcostal. Yes. Another. Suppose very large spleen, large
both the sides you want to open.
We can only think of phalangeal incision is for lower abdomen. So upper abdomen, what is that incision?
Focus incision.
Double?
Both sides.
Yeah.
Both, no? Suppose you want to tackle the liver, spleen, or left thoracoabdominal. That used to be put also,
Okay.
So because what is the problem of this? Nicely healed, no incisional hernia. That's a different issue.
Yes.
But how do you rule out incisional hernia here?
The cuff impulse was negative. Cuff impulse was negative. Cuff impulse was negative, and there was no defect palpable. Sir.
Have you said that cuff impulse is negative?
No, sir.
You are presenting a lot of other things, but what?
These are very relevant. You are right cutting through. Children, it is preferred, Children.
Yeah, that's what. Upper transverse, mid transverse, lower transverse.
So,
at one side, it's commonly used for pediatric cases.
So this is, you see, it is cutting through rectus, everything there.
Yes.
See? But whatever healed nicely is a different issue.
Yes.
So, but just
you're sure it is a scar, no?
Yes, sir.
Yes.
You were discussing more about abdominal swelling, no?
Yes, sir.
Do you consider a swelling in the abdomen? Clinically, you say a swelling or mass?
Mass.
So you just discuss about that mass. Where is the mass? No? Your description is not very clear. Which quadrant it is?
It was in left hypochondrium, sir, and extending to epigastrium. Yeah.
Sir, basically, I think he wants to say it's a liver. He has written round. He has written.
How can it be?
Left.
You said upper part is not palpable, but you are very obviously seeing it is around 10 to 8 centimeter.
Left to epigastrium, smooth, round, slightly moves with respiration. So that's what. Upper border not palpable. So
then how do you measure the size?
The borders that are palpable, I have measured that only, sir.
That is round.
Approximate. Yeah.
It is round.
Was the mass continuous to the liver dullness?
Yes, sir.
That not you have to tell, no?
Yeah.
You are not mentioned about your percussion finding, the size of the liver, what is the span of the liver?
Sir, he has mentioned percussion, dull he has mentioned. So, he has mentioned, but span and the rest of things he has not.
And you have put a one word called audible bruit. No audible bruit. Where do you look for audible bruit here? What is non-audible bruit is there? Or where do you look for bruit?
In the epigastric region, sir, for aortic swelling, sir. Swelling arises above the aorta.
So if the swelling is arising in the aorta.
Yeah.
So you will get a bruit there.
Yeah.
Out. Swelling
Transmission
arise
above the aorta. Transmission of aortic impulse.
transmission
What about
pulsation.
drop space? You never mentioned about drop space.
Obviously, your swelling was in the drop space.
Yeah.
Have you checked
Sorry.
for it on trees?
So just when you give a diagnosis, I understand that you are dealing with the liver, okay, as per your description. I
Yes.
think you should confine yourself to liver based on your previous records. I'm not sure 20 years of age, whether this patient had 20 years, no, when she had that.
Yes, sir.
So you also need to give when she was very young, 20 years. If you want to
Yes.
correlate, it can be a simple polycystic disease also. You need to go in that direction.
Okay.
Understood what I'm telling?
Yes.
Because hydrated cyst, nothing that nothing like you can't get in 20 years, 8 years, 10 years like that. Totally asymptomatic for last 20 years, correct?
Yes, sir.
Yes or no? With absolutely nothing there. So somebody removing the spleen also. So hydrated of the spleen. See, difficult to imagine hydrated of the liver, hydrated of spleen in a 20-year, of course, background and all we don't know. Only accordingly you said she's from UP. That's all.
Yes.
Otherwise, no other details available. So just keep that in mind instead of trying to go for other things. Okay, smoother, rounder, well preserved lead accordingly.
Yes.
No weight loss, nothing, no? Yes?
Yes, sir. Nothing. Yes.
Is it a cystic or a solid swelling? I mean, mass or variable consistency? See, clinically, you are telling there was mass continues with liver dullness.
Yes.
Is it having the same consistency as that of the liver?
Yes, sir.
Or is it a firmly cystic mass?
Same consistency as of liver, sir.
I think it's a solid mass.
Yeah.
See, clinically, you have to make out this.
You get a hydrated solid mass.
We can get, sir.
So what stage?
Stage 5, sir.
Stage 5.
Yeah.
See, whenever you make a clinical diagnosis in an abdominal mass, you must clearly be organ specific. From which organ it arises from?
Yes.
Whether it's arising from the liver or is it not arising from liver? Maybe maybe other cystic swellings in that region. You should clinically tell, right?
Yes.
Spleen is not there already. Splenectomy being done. Is it anywhere related to the pancreas?
No, sir.
Gist
There was
also,
no.
Gist is also ruled out.
Yes.
How?
Because there were no symptoms suggestive of early satiety or.
It's not mandatory. If it is coming totally extra coming out, there is no need to produce.
Yeah. It need not produce. Was there any hematemesis history?
No, sir. No hematemesis.
Elish, what is hydrated thrill?
I'm not sure, sir.
Hydrated thrill is like in the liver where hydrated is there. You put your 3 fingers and percuss on one finger and you can feel that there's a thrill which is felt on the other fingers.
Okay.
Okay. And what is left? Hypogastrium, you have written somewhere? Left hypogastrium?
Hypochondriacism, sir.
No, you've written somewhere left hypogastrium, isn't it? That is
I need
probably
to say hypochondriacism.
no in your summary slide, And your summary slide, you have written somewhere the left.
No, sir,
Hypogastric.
that too. No, I meant to say hypochondriac.
Okay, so that's it.
Yes.
Yeah.
Yes.
For gastric.
Yeah, yeah.
Yes.
Written.
Yeah.
And how do you explain the
Hypochondria.
significant weight loss? If you are thinking a benign lesion,
Yes, sir.
but if patient is not anemic, otherwise all our features are normal. But you are saying now there is a significant weight loss. And but the picture also doesn't looks like that she has lost weight unless we know that previously she has. Wait. What is her weight now? Almost
58 kg.
58 kg. Then how do you come to a significant weight loss?
Sorry, sir. What?
No, you have.
There was no significant weight
No
loss.
significant.
No
Okay.
history of no history.
So let's, what is malignant hydrated?
The Echinococcus multilocularis is associated with malignant hydrated, which can undergo malignant transformations due to prolonged inflammatory response.
It will undergo malignant transformation.
See, you are just reading by word. Is it so?
This is a misnomer name. Huh?
Yes.
It will mimic like malignancy. Not it will not.
It produces a lot of morbidity as if it looks like malignancy. It is not malignancy. It will not produce malignancy. It's a misnomer, as you said. But patients will become so cachexic and look like a malignancy patients. That's all.
Okay.
And especially it is a cystic echinococcosis.
Yes.
What are the investigations you have done in this case?
Yes. Investigations are complete blood counts, liver function test, imaging studies, and serological studies. In complete blood counts, we look for CBC, hemoglobin, and platelet counts. Sir. In liver function test, alkaline phosphatase, SGOT, SGPT, and
In case of hydrated, what will be there in the complete blood count in hydrated?
It can be normal also, sir, and if it can be normal also. Or if patient is receiving some medications for hydrated, then there can be a granulocytosis.
Normally, in a
parasitic infection, what will be there?
You look at the differential count.
Eosinophilia will be there.
Yeah, eosinophilia, na?
Yes.
Yes.
What was the imaging here in this case?
USG and sir, CT, sir.
Can you tell about the findings here in this patient?
Yes, sir. This is CT of this patient, sir. Having large 10 into 8 into 8 centimeter solid lesion with calcified wall in left lobe of liver and abutting anterior wall of stomach, sir. Without any septated or loculated lesions.
C5.
What is the LFT of this patient, doctor?
Within normal limits, sir.
Within normal. What is the alkaline phosphatase in this patient?
170, sir.
Is it in the normal range or raised?
We can consider it normal, sir.
So is it possible? See, what happens in even a small intraparenchymal this thing, there will be raise of alkaline phosphatase. Why?
Because of compressions.
Why compression should, there is such a big mass you say within the liver,
yes,
can't it change the alkaline phosphatase? Why alkaline phosphatase is so sensitive, it will raise immediately even if there is any compression. That is the reason in a small meds also you will get raised alkaline phosphatase. Such a big mass, there is no raise in alkaline phosphatase, surprising. Why actually alkaline phosphatase raises in compressions? This alkaline phosphatase is synthesized in the biliary canaliculi. Any biliary status stimulates the increased synthesis of this alkaline phosphatase, and it will be released into the blood. That is why small biliary stasis, because of the compression, small meds, there will be raise of alkaline phosphatase. But I'm surprised in this patient, alkaline phosphatase within normal limits according.
What is your, inference with this CT?
That it is a solid calcified wall having around size of 10 into 10 centimeter in left lobe of liver, which is not communicating with biliary or pleural cavity and
Is it a
compression.
cystic or solid lesion?
Solid lesion, sir. Having solid component.
Remember that. See, is it a cystic or solid? The liver you are able to see. The other side you can see. Calcified lesion.
Yes, sir. Calcified.
Already operated.
Yes.
For hydrated. Or late.
Have you done ultrasound for this patient, doctor?
Yes, sir.
What is ultrasound finding? Is it cystic mass, solid mass?
No, sir. Solid mass. They have written solid mass.
Even an ultrasound?
Solid lesion. Yes, sir.
Is an active cyst or inactive cyst?
Inactive cyst, sir.
Inactive cyst.
Yes.
Okay. So Garbi classification is on
USG findings, sir. It is the type 5, sir. Garbi's classification type 5, solid and calcified lesions.
Okay.
You have done the serology also in this patient?
No, sir.
Which serology is done for the hydrated?
Immunoglobulin E level, sir.
What is Cassini's test?
Hypersensitivity to antigens, sir. Echinococcus antigens.
How it is done?
Exactly, I'm not sure, sir.
You have to inject the sterilized hydrated fluid which is there, no? And see further how much the reaction is there. Okay.
Shailesh, to know the solid or cystic, have they given this Hounsfield units here? Have they measured in that way or just?
It's only a calcified rim is there solid, but in contents, yeah, sure.
That's why.
It looks more like a cyst, sir, with a calcification.
Definitely.
Being a hydrated operated, recurrent.
Yes, sir.
And already it is a calcified. That means it's a recurrent, already dead cyst.
Yes.
Right? The natural way of
Elimination.
healing.
Retrospectively, have you asked any risk factor or any history? You could get it?
Yes, sir. History of contact with dogs, pets. There was no such history.
Just wanted to ask you, in this picture, I can't show you. There's a rim calcification. Then other side, what is the structure on the left side?
Stomach.
So what is how stomach is delineated by giving what?
Contrast.
So look at that. Actually, so it's a liquid or solid. I mean, it's difficult at this juncture for me to say, but most of it looks Hounsfield units. You have to check.
Yes, sir.
You understood? Look at the liver there. Liver.
Yes, yes.
See, no comparison always. No, that's what I'm trying to tell.
Yes.
Okay.
Yes.
How will you proceed?
For management, we can undergo medical management or surgical management. And there are indications and contraindications for each of those. Medical management, the indications are if the patient is refusal for surgery or inoperable cases, or cystic lesion greater than 5 centimeter in diameter or multiple cysts or relapse after a previous surgery, then we can initiate medical management. And for surgical management, there are different conservative and radical surgeries, such as cystectomy and then capitonage and liver resection, partial or total pericystectomy, sir. And we can also undergo pairs, sir.
What you are planning for your case?
We have given sir medical management.
You said it is a dead tissue.
Yes, sir. But
What is the point in giving a medical management?
yes, sir. The patient was reluctant for surgery. We have advised, but she was reluctant, so we have started on medical management.
No, what is your logic behind starting a medical management for a dead tissue as per your statement? It's a calcified,
Yes, sir.
non-functioning tissue.
Yes, sir.
Is you are expecting the medical management is going to help you?
Not much, sir.
So how
Have you
long you are
seen
going to give?
hydrated surgery, doctor?
Sorry, sir.
Have you seen any time hydrated surgery excision?
No, sir.
What are the precautions taken?
Preoperatively, antihistaminic can be given, and the medical management can be started, sir. And then
Don't worry. Being a surgeon, don't worry about all those things. What you will do during surgery?
During surgery, we have to take care of peritoneal seeding, so we have to put gauze or
spillage.
Spillage, yes, sir. We
You
have
have to
to
do
prevent spillage, sir, by
what are the scolicidal agents used?
hypertonic saline, sir, sodium silver nitrate, and ethanol.
You want to damage the liver?
So mebendazole can be also used, sir.
How difficult is this surgery?
There are risks of hemorrhage, sir, spillage, sir.
It's a treat to watch when you do a hydrated cyst surgery, right? After injecting the hypertonic saline or even a povidone-iodine mixed saline, the cyst collapses, the bubbles collapses by itself. And opening the cyst wall, avoiding spillage, you can just scoop out everything, all the scoliosis, and you can just peel off the laminated membrane. It will just come out like a coconut, right?
Okay. Yes.
Look for any biliary leak.
Yes.
Sometimes there will be a communicating one, but there will be a biliary leak. In that condition only, it is you have to take care in suturing the biliary leaks. Otherwise, deroofing, removal of the cyst and the laminated membrane, and keeping a drain
Momentum.
as well as you have to reduce the space. Right? Dead space reduction is enough for the thing. Avoid spillage. That is the motto in this surgery. See, obviously, you must see to believe it.
Yes.
Right? Hydrated is such a interesting case to operate. Right?
Yes.
So how long you are going to put the patient on medical management here now?
Sir, if patient is they're planning for surgery, if patient and relatives are okay, then we can proceed, sir, for surgery.
So till then you will start on medical management.
No, sir. We give for 3 to 4 weeks, sir.
What is the prognosis? If you are supposed he is not undergoing any treatment, what you are expecting this?
We'll have to take regular follow-up, sir, and then based on that we can decide.
Most of the time, nothing will happen.
Okay.
This patient, if she has no other pain problem, and it will be there because already it is calcified, and unless he's having a further exposure, further things. What are the other complications you are expecting from this?
It can undergo rupture or hematoma hemorrhage within, or biliary involvement, sir.
Dr. Sailesh. I'm sorry, sir. Please go ahead, sir.
Okay,
Dr. Sailesh, What is the current recommendation? You talked about medical therapy. I'm sure you have studied that. What is the current recommendation of pre-procedural antihelminthic usage in these patients?
We have to give, sir, anti-helminthic for 1 to 2 weeks, sir, twice daily.
Which article or which guideline practice parameter refers this? You say that Infectious Disease Society guidelines or the tropical hygiene, the British Society of Tropical Hygiene. These are the two important tropical diseases recommendations which we have to follow.
Okay.
Optimally, if there are no complications, you have to treat this patient for a minimum of 6 weeks. Right? So, what is the stipulated dosage? So, you have to go minimum of 1200 milligrams per day.
Yes.
Right? 1200 milligrams per day. I'm talking about a standard 60 kilograms adult. All right. So, you go for 1200 milligram of albendazole. Usually, what you do is you give for 3 to 4 weeks. And then give a gap of 1 week and then give for another minimum of 2 weeks to 3 weeks. Because what happens is, the moment these drugs are used, the tortoises or the fertile scoliosis, they don't hatch. They go to a dormant mode. Once you stop the medicine, they feel the threat is gone and they start opening up. So that is why they give a gap in between the two schedules of albendazole. All right. So once these things are completed, then you take them up for surgery with, as per the earlier discussion, what are the standard precautions you follow. But then, if there is a complication, typically complication by mean, we say dissemination, we see intrabiliary spread of hydatid, presence of cholangitis or presence of sepsis, systemic sepsis. These are the typical things. Then we have to take these patients up. There are some specific countries which have IV albendazole also. I'm not sure whether that is available in India, but at this point of time, you can take this patient as an emergency, right? So there are some specific drugs, like you can also use mebendazole also. There are other drugs which the newer generation drugs which have come in. Fortunately, these parasites have not developed resistance to these medicines. So we are still able to continue to use the same medicines. All right, this is the pre-procedural.
Yes.
After you remove, you have peri-procedural or post-procedural chemoprophylaxis for these patients. You have?
Yes, sir.
How long? And if so, what drug?
We can give albendazole for 4 to 6 more months, sir.
Correct. So the point is, you have to keep them. Okay, I'll make question life easier. How do you follow these patients up? You have done a successful removal. Patient has gone home without any trouble. When do you ask them to come for a review, or when do they have a recommendation for a repeat image?
6-month follow for first 2 years, sir. Then yearly follow.
Okay. How do you follow these patients up?
We'll have to do a basic blood investigation, sir, and USG and CT imaging, sir.
The recommendations are annual for 3 years imaging, but then these things can even come after 20 to 40 years. That's the message. You should be loud and clear. We don't have a reason to understand this. People believe they can be prone for reinfection, but then with the modern amount of protective precautions, halaling of the meat and proper cooking of the meat, these things are not supposed to happen. But that obviously means there are other sources which, as of now, we do not know why and how these things can get into the human body.
Yes.
What type of host is human in hydatid?
Accidental loss, sir.
Correct. So it is a end host, host, because the life cycle do not progress once it enters into the human.
Yes.
Have you seen how a lung hydatid and a liver hydatid is different between each other? You have not seen the operating any hydatids, is it? Okay. You have nice YouTube videos. In lung hydrated, you just open the chest, ask the anesthesiologist to close the PEEP valve and just bag the patient. The hydrated gets simply popped out and the surgery is over. That easy it is. But again, intraparenchymal are very, very rare, but you also have to look for. Whereas liver hydrated, one have to be very careful. They are not that easy. All right. So post-procedural bile leak after hydrated excision, how would you like to manage?
We can put a
Scenario, 300 ml bile every day in the drain tube.
Yes, sir.
12 days after the surgery, it is continuing. How do you like to manage?
We'll have to do imaging, sir, MRCP, and then plan for.
MRCP do not normally help in these patients. It is preferable you have a dynamic imaging. What are the potential dynamic imaging you like to use? You please go and read what are the dynamic imaging. MRCP, there is a patent. Like structural, many times they don't have large patency. It will be cholangiolar level patencies which could be existing. Many times these patients, how you manage the same thing like a biliary leak following a cholecystectomy, something like that. Same policies apply for this. You do a ERCP, wide sphincterotomy and leave a stent. Once the pressure on the biliary sphincter is decompressed, generally these bile leaks will resolve by itself. Very rarely only, you may need to have some form of cholangioentral anastomosis. These are all pretty rare. All right. So, can you, have you read about the pathology of the hydrated, walls of the hydrated, layers of the hydrated?
Yes, sir.
Tell about it. What are the true walls? What are the false walls?
True walls are formed by the hepatic parenchyma, and false wall is formed by the reactionary.
Okay, fine. So, is there any very recent development for a understanding? Sir was asking about whether it's a dead cyst or a live cyst. Do we have any recent investigation to understand that?
We have USG findings, sir.
USG finding or corroborative or specific?
No, specific.
So I'm not going to tell. In the next class, I will disclose. This is a homework for all of the students. Go back and read. We have very exciting developments on the imaging of parasitology coming up. So I wish all of you go and read. Next class, I will certainly disclose all the answers. Faculty, I'm sorry I've taken much of your time. Do you have any questions or comments, or can we call a close, sir?
Yes,
No,
he has presented well.
What is the source of this infection?
Mostly, sir, herbivorous animals. Herbivorous animals.
No. What is going to get? How do they get the infection?
By eating meat, sir.
It contains what? Egg, larva, or what is this?
Yeah, it contains larva.
Larva.
Which is transmissible, ma? That is the question, Sailesh.
Yeah, that is what I'm asking.
Please, moment to understand. I know you are tired, but then the host to the, like from the organism or the parasite to the host, how the transfer happens?
First, the definitive host ingests the
no,
tissue.
like that. Let us limit to like the end host, like in human being. How it reaches to the liver?
By portal circulation, by hatching in the intestine.
No, before that, how it enters into the human body and then gets into the viable reproducible organism.
Ingests the eggs by
eggs. That is what, but you said larva.
Fertilized eggs.
Yes.
It is not the larva, it is the eggs.
Yes.
So how long these eggs can be viable in the soil?
Not sure about duration.
Many years.
Yes.
All right, many years. Right. So go back and read the Manson's textbook of tropical disorders as a very wonderful treatise. All the postgraduates take note of it. The Manson's tropical diseases gives the excellent coverage of hydatitis. I request and recommend all of you go back, sit in the library and read up this one full chapter. You will be fully confident about handling these cases. Any other faculty would like to give comments? Umakant sir, thank you for joining us even for a benign case.
Thank you
I
so
know
much,
you are a
sir. Thank you
surgical
so much
oncologist.
for inviting me for this. It was a
No,
wonderful
sir.
case discussion, sir.
Sir, this happens all Fridays. God has been kind. Today we are running 257th session.
Yeah, I know, sir.
happening.
Dr. Sridhar told me actually.
So it is like a voluntary contribution. Many of the faculty here have been with us multiple times. Kanan sir has been there for many times. Jalal sir is
Sir, I'll be
almost
glad if
come.
you. I'll be glad, and I'm interested in participating in this thing, sir.
Sir,
Next time
whenever
also,
there
if
is
you
a
call me.
CA case, I will inform you, sir.
Today, I'm coming from the conference of liver transplantation, which is happening in Hyderabad. So
Oh,
today I was
amazing,
not
sir.
able to really. That is most of the times I was in the car. Next time I will definitely spend my time. I will actively participate.
Much appreciated, sir. Much appreciated, sir. Any other comments from any other faculty? So without all good things have to come to an end. We call this session a close.
Only thing I just, because this is a little tough case for you to present, because it's only calcified margin, and the systematic presentation is very important, because you know the diagnosis. That is why you are leaving a guide.
Yes.
But come with the open mind and present, and the basic things of examination you should say.
Yes, sure. Thank you.
Good luck.
Always have an opportunity to at least assist a case of hydatid or to observe in a YouTube. No?
Yes.
It will be quite fascinating.
Yes, sir. We'll do sure.
To
Any
understand
Indian
the
who have
subject.
invented a special trocar for this operation?
Rangabhashyam.
No, sir. No.
So he had one funnel was
I'm
there.
not sure, sir. Professor Palnivelu sir's trocar is one thing very
That's for
popular.
lab, sir. But open surgery,
Rangabhashyam.
and a
Okay,
funnel
sir.
like
Probably I'm unaware.
Okay.
What is special about it, sir? If you can quickly tell.
No, it just keep that funnel there. So the
Okay.
It prevents spillage, sir. It prevents spillage.
Okay. So,
So days
good night.
actually the scoliocytes were not that used. They used to open and then remove the bubble-like structures. No, they were fond of removing that, but that is a dangerous procedure.
Unsafe, sir. Unsafe for the handlers also.
Yeah, that's what. Bubbles of
Sir,
various types.
Sir,
But
now
after the scoliocyte, it get collapsed. So it is very easy to pick up with even a sponge holder.
Sir, it becomes a dirty sludge, sir. That is all. Now, after the treatment of complete eradication for 6 weeks of albendazole, it is like a dirty, necrosed sludge material only we get, sir.
In ESA Ayanapuram, myself and Dr. Rajendran, we operated a case of hydatid in the thigh.
Yes, sir.
Yeah. 15 into 20 centimeter. And we collected a full bottle of this soap bubble like this hydatid cyst. Very interesting one, because this village is going to go down only. It's not going to any other structure. In abdomen, it's difficult. Even a small spillage will lead to recurrence.
Thank you, sir. Thank you very much. Good night, everyone.
Thank you, sir. Good
We call
night.
the session a close.